joining from rest part of the world. Today we have got two lectures. The first guest speaker is Dr. Priyanka Samal from Bhubaneswar, India, and she will lecture us on acalabrutinib in CLL, a real-world experience. And the second guest speaker is Dr. Elena Gary from Vancouver, Canada, and she will be lecturing us on chronic lymphocytic leukemia and update. This webinar is brought to you by Mumbai Hematology Group, supported by AstraZeneca and Nirvin Life Sciences, and managed by Perfect Square. I thank Mr. Manoj Singh Rawat and the team from AstraZeneca, Mr. Paresh Prabhugaonkar and his team from Nirvin, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers for the day, Dr. Priyanka Samal from Bhubaneswar and Dr. Elena Gary from Vancouver, Canada. All our discussants were themselves eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening, morning, and afternoon. Tomorrow, that is 11th of June, Sunday, we have a webinar on mimickers of Hodgkin's lymphoma at 11:30 a.m. by Brigadier Tathagata Chatterjee from Faridabad, Haryana. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Akash Khandelwal from BLK Max Hospital, Delhi, Dr. Annie Kanchanba from St. John's Medical College Hospital, Bengaluru, Dr. Amrita Chakrabarti from Max Hospital, Delhi, Lieutenant Colonel Dr. Kundan Mishra from RNR Army Hospital, New Delhi, Dr. Mukul Agarwal from AIMS, New Delhi, Dr. Miyat Malla Shwe from Mandalay, Myanmar, Dr. Nidhi Jain from Zydus Hospitals, Ahmedabad, Dr. Nikhil Kumar from AIMS, Delhi, Dr. Nirali Chandan from Saidri Super Specialty Hospital, Pune, Dr. Nupur Patil from TN Medical College and BYL Nair Charitable Hospital, Mumbai, Colonel Dr. P. Suresh from RNR Army Hospital, Delhi, Dr. Pooja Prasad from Homi Baba Cancer Hospital and Research Center, Punjab, Dr. Rajat Jain from VMMC and Safdarjung Hospital, Delhi, Dr. Roshni Pandey from Mahakoshal Hospital, Jabalpur, and Dr. Roy Palati from AIMS, Delhi. Let me introduce our first guest speaker for the day, Dr. Priyanka Samal from Bhubaneswar, India. Dr. Priyanka Samal is MD, DM in Clinical Hematology, Professor and Head, Department of Clinical Hematology, Hemato-Oncology, and Stem Cell Transplant at IMS and some hospital, Bhubaneswar. She will be lecturing us on acalabrutinib in CLL, a real-world experience. Over to you, Professor Dr. Priyanka Samal. You are muted, Dr. Priyanka.
Yeah. Good evening, everyone. Thank you, MB Agarwal sir and Dr. Amit Khurana for that introduction and giving me this opportunity today evening. And thank you, AstraZeneca, for having me here as a part of the discussion today. So I'll be speaking about, can I share my screen?
Yeah, sure. Please go ahead.
Yeah. So today I'll be speaking about the real-world experience of acalabrutinib in CLL. Yeah, are my slides visible?
Absolutely, very clear.
And it's all moving, right?
Yes, perfect.
Yeah. So we'll be talking in the next few minutes, approximately 30 minutes or so, regarding acalabrutinib in CLL and real-world experience. And I will be sharing the experience we had at our center. And to start with, we know that CLL is a chronic condition and it may require a long-term treatment. So the tolerability is a very important key consideration to be taken care of. And since the age of diagnosis is approximately in the 7th or the 8th decade of life, with a median age of presentation being at 72 years, we see that approximately 90% of the patients present at an elderly age group more than 55 years old, and in India it is still a decade earlier. And 89% of these patients have one or more comorbidities at diagnosis. So this makes it very clear that since we have a long-term treatment with this oral Bruton kinase inhibitors, definitely we need to consider about the comorbidities so that it can be given for a longer duration. And it is rarely a curable disease. We know it is an indolent lymphoma and therefore rarely curable. However, we're looking into MRD these days on CLL, trying to have a halt to the therapy and a lot of other discussions which are new updates in the CLL, which will be taken up by the next subsequent speaker. So it may require treatment and a long-term follow-up is recommended for these patients. So since I'm talking about the real-world experience, I tried to collect my own data in the hospital, that is our own department, which has been serving both the hemato-oncology patients as well as the benign patients. So looking into the cases right from 2018 when I joined the hospital and was active in managing the patients till 2023, we found a total number of cases of 51. Total number of males were 37. Total number of females were 14, and the male is to female ratio was slightly more of male predominance with 2.64:1. So age at presentation, as I said, in India, things are a little bit earlier, a decade earlier. So 36 years was the youngest age at presentation till 78 years of age. Median age was 64 and mean age was 61.1 years. So if we look into the category of the CLL patients who have received therapy or have been asymptomatic or on follow-up only, we found that asymptomatic patients who are just on follow-up with us at present are 10. Patients who had received bendamustine and rituximab, which was the chemoimmunotherapy or the standard of care approximately 4 to 5 years back, and those who are on follow-up were 14. Ibrutinib out of the total 51 cases. Ibrutinib we had started on 4 patients when it was available to us in India since 2020. On acalabrutinib, 6 patients died of the disease or of the comorbidities 10, and we could not find details of some of the patients, like 6 of them. And to mention about it, because we are talking about acalabrutinib today, 1 out of the 6 CLL patient on acalabrutinib died, and I will be discussing regarding that case, whether the death is attributed to her age-related ailments or it was related to acalabrutinib. We will see in the next few slides when we discuss regarding that case. So this was the distribution. We can see that patients on who are asymptomatic and on follow-up, approximately 20% of the cases, and you can see there is a good number of cases on bendamustine rituximab, and then the acalabrutinib, and still lower was the ibrutinib arm. So if we look into the guidelines, what is the present era, the first line therapy in patients without the bad markers, that is deletion 17p or TP53 mutation, irrespective of the patient's age. You can see over here the patient's age more than 65 years or patient age less than 65 years with significant comorbidities. Preferred regimen is acalabrutinib plus minus obinutuzumab, ibrutinib, venetoclax plus obinutuzumab, and zanubrutinib. So these are all category 1 indications as per the NCCN 2022 guidelines. And the patients with less than 65 years without significant comorbidities, even for them, the preferred regimens are acalabrutinib plus minus obinutuzumab, ibrutinib, ven plus obin, and zanubrutinib, and again these are category 1. And then after that, if your patient does not fall into these categories of having these drugs, I think rarely this happens, then there are other recommendations with chemoimmunotherapy like bendamustine, chlorambucil, and the others like FCR. So that was regarding patients who had favorable genetics, but patients without deletion, just a minute, this was without deletion 17p and first line therapy, and this is in patients without deletion 17p, TP53, and in the second line or the subsequent therapy. So these again, both the criteria is being met clinically, like the patient's age and the comorbidities. Still the preferred regimens in the category 1 remain the same, that is the BTKI inhibitors, venetoclax. And if in case the patient had other regimens, then you can consider other recommended regimens like chlorambucil, rituximab, obinutuzumab, ofatumumab, etc. So those were the patients who were with the good genetic markers or mutation status. And in these patients, where there is presence of deletion 17p or TP53, or there is mutation of the IgHV immunoglobulin gene rearrangements, if they are these are unmutated, in those cases, chemoimmunotherapy is not recommended. Since the response rates are low, the relapse rates are high. Therefore, the first-line therapy for these patients, the preferred regimens are again the BTKI inhibitors, whichever is available to you, and based upon the comorbidities, along with BCL2 inhibitor like the venetoclax and the obinutuzumab combination. Second-line therapy again for these patients also remains the same. So looking at both the tables, we find that the preferred regimens category 1 indications throughout, whether in the frontline setting or in the relapsed refractory setting, remains the BTK inhibitors and the BCL2 inhibitors, and possibly we are going away from the chemoimmunotherapy, which was earlier the regimen of choice. So how do we decide regarding that? Key factors when selecting the treatment for CLL, as we looked into how the NCCN guidelines are framed based upon the mutation status. IGHV mutation for the first line, it does not change right from the outset when the patient presented with till the last. And then deletion 17p status or the TP53 mutation status, it can change when the patient presented with, when the patient enters into a phase of Richter's transformation, or even when the patient relapses. So we need to look into the status when we are starting therapy in a patient who has relapsed or has presented at the outset, and we are planning to start a therapy for the patient. The BTK and the PLCG2 mutation status, not currently the standard of care to be looked into, but in patients who are BTKI inhibitors, they have already been exposed to this therapy and they have relapsed or they are not showing a response. In those cases, we should assess this mutation status. And most important, being because we have a basket of choice available with us, the age, comorbidities, as well as the financial status of the patient decides regarding which therapy to start with. So since we are talking today about the small molecule acalabrutinib, which is a highly selective, potent and a second generation BTK inhibitor, we need to know why this second generation BTK inhibitor came after the first generation ibrutinib was launched. So we needed to see and understand that over here in the if you look into the ibrutinib diagram over here, there are a lot of other inhibitors also apart from the Bruton kinase inhibitor, like the TEC inhibitor, the EGFR inhibitor, the ITK mediated signaling. These are also inhibited, and as a result of which the off-target kinase side effects of ibrutinib are seen, like the atrial fibrillation, like more amount of bleeding in these patients, and the intolerability regarding the diarrhea or the other side effects in these patients who are on ibrutinib. So when we look into the acalabrutinib dendritic chart, here you can see it has a fast, near complete and sustained BTK occupancy at the recommended oral dose of 100 milligram twice daily. So it has a high selectivity for the Bruton kinase, binds more covalently or tightly covalently bound to the Bruton kinase with limited off-target activity and hence better tolerable. So as we discussed in the initial slide, that this CLL is a disease of the elderly where patients have a lot of comorbidities. Most of the time in the 7th and the 8th decade of life, we find many patients with type 2 diabetes mellitus, with bad heart disease, with hypertension, which are many a times uncontrolled. Therefore, a drug which has lesser side effects or off-target target side effects, it should be a better tolerable drug than a drug which has more number of side effects. So with that brief introduction, now I would like to start with the cases we had treated and the cases which actually were something which were eye-opening, or patients who had helped us learn a lot from their own way of presentation. So there will be 5 to 6 cases we'll discuss, and that is what the real-world experience of our institute remains. So this is a 76-year-old female presented with sudden onset of dizziness, disorientation, and difficulty in breathing right back in 9th December 2020. She was admitted to a local hospital, investigated and diagnosed as dyselectrolytemia with sepsis. She had comorbidities, hypertension and diabetes. Chest X-ray showed right upper lobe mass with pleural effusion, and the PET CT scan done outside showed evidence of CA lungs with METs. So CT-guided lung biopsy was advised and done by the medical oncologist, and following that she had hemorrhagic pleural effusion, as a result of which an ICD was inserted. Meanwhile, when the CBC was done, something came out like a high TLC count, and there was a lymphocyte predominance, and hence a hemat consultation was given. She had a hemoglobin of 9 gram percent, TLC 26,000, platelet count of 1.2 lakhs, and the differential showed neutrophil 35 and lymphocyte 65. So this was something which was a report from outside. The LDH was 250 units per DL. LFT, RFT mildly deranged. The patient was also in the ICU. Pleural fluid aspirate showed atypical lymphoid cell infiltration, and urine RE showed Candida tropicalis. So we reviewed the peripheral smear. There was presence of smudge cells, predominantly mature-looking atypical cells. General examination, no lymphadenopathy, no hepatosplenomegaly. Asked for a peripheral blood flow cytometer, and it was suggestive of CLL, as you can see, surface immunoglobulin positive, CD5, CD23 positive, and CD200 positive. So after looking into that, we need to rule out the other causes of anemia. So DCT, ICT done, it was negative. Managed with NIV and supportive therapy, antibiotics, and antifungals. Hemat consultation, after it was again redone, or a review was done, and patient was advised to be discharged. After stabilization, a definitive therapy was to be thought of because she was in the ICU or got a hospitalization, and subsequently whether the hemoglobin is coming up or not, or there are indications to treat a patient of CLL, we wanted to know that. So in the meantime, the biopsy came, the lung biopsy, which the patient had presented with. And you can see over here, small cells, monotonous looking cells, and it is spread in sheets. Here you can see CD20 beautifully positive, CD5 positive, CD23 positive. So the PET scan, which had reported as a CA lung, it was definitely even a CLL mass sitting right over there in the lung. So as per the International Working Group of CLL guidelines, since the patient was symptomatic with just anemia, one of the causes which was not which may not possibly be because of the disease itself infiltrating the marrow. But then if you look into the other causes or the criteria for which a patient needs to be started on therapy, for this patient, the patient was symptomatically had a functional extranodal involvement like the lung, and she had presented with having a shortness of breath and dyselectrolytemia in the hospital. So when we started, that was something, ibrutinib, I think that was the first case we had when we started on ibrutinib, and we looked into the CLL IPI category, and then they had mentioned over there that TP53 aberration, prior treatment, beta-2 microglobulin more than 5 milligram per liter, and LDH of more than 250 units per liter. These were the 4 factors which actually prognosticated the patient, because apart from the Binet and the Rice staging, this is also something which needs to be considered in the area of BTK inhibitors when we are using ibrutinib and acalabrutinib. So this is one of the criteria, CLL IPI category, and you can see over here the low risk, they have OS of 93.2%, almost that of a normal population, do not need to treat. Intermediate risk, 79% OS at 5 years, do not treat except if the disease is really symptomatic. High risk, 63.3%. Treatment indicated except if the disease is asymptomatic, and very high risk, 23.3%. If you need to treat, do not use chemotherapy, but rather targeted agents or treat in the clinical trial. So this patient of ours was in the very high risk group, and we started therapy. We decided to discharge the patient home on oral antibiotics and antifungals, get the patient stabilized, and asked to follow up of 10 days so that we can think of starting the therapy for the patient in the next visit. She also required BiPAP at home for her bad chest. And during the same time, the IGHV mutation status, we got the result and it was unmutated. TP53 was wild type, FISH panel was negative. Patient was initially started at Visolone 60 milligram OD for 5 days because the patients were still apprehensive of regarding the starting of therapy for CLL, having been diagnosed with a cancer, and then starting on something oral chemotherapy. They were very apprehensive. So patient was started on Visolone 60 mg OD for 5 days. And then they were counseled regarding the start of therapy with the oral BTK inhibitor, which the patient can comfortably take at home, does not require much of monitoring for any TLS sort of a thing or any other side effects. So counseling was done. Evaluation in the meantime was done for cardiac comorbidities and for bleeding parameters if the patient had earlier anything. Patient's relatives still apprehensive for starting the drug because she was requiring oxygen at home. Finally, after 1.5 months of a presentation in Jan, she started the drug, tolerated it well, and she was off oxygen support within 7 days of starting therapy. So totally, she had been discharged home, and 1.5 months she was on oxygen support. But just after starting the drug for 7 days, the patient had a sense of well-being, and she was off oxygen support in 7 days. The whole idea was to say that in a patient, when we started ibrutinib for the first time, this was an atypical presentation, and we wanted to be very safe because, with a bad chest, rituximab many a times is problematic in patients and they land up in a ventilator support. So the treatment continued. In view of COVID restrictions at that point of time, patient had very infrequent visits or follow-up with us. We were also not very much aware how this drug is acting and what is happening to the lymphocytes, because we knew that the patient will have a lymphocytosis, and the patient was previously very much apprehensive about that. So how they will take, how the patient's family will take. So she had very infrequent visits with her. But then after the counseling, the lymphocytosis, it normalized after 8 months of starting therapy. Chest X-ray resolution of the mass just within 1 month of starting the drug. So this was the X-ray, a beautiful X-ray she had. Then on further follow-up, that is 1 year later, 24th of Jan 2022, she was readmitted in the hospital for similar complaints of disorientation, incoherent talk, and slurring of speech. MRI, brain, and other investigations done, diagnosed as hyponatremia with dyselectrolytemia. She had malignant hypertension and uncontrolled type 2 diabetes mellitus. So management again in the ICU was done. She was stabilized in a week's time. She was stopped ibrutinib on the admission of her when she was admitted in the ICU. So at that point of time, that is 1 year later after her starting ibrutinib, hemoglobin was 11.8, PLC 12,600, platelet 1.87 lakhs. DC was 65, lymphocyte 21, that is a normal DC. There was no lung mass, but there were infiltrates in the bilateral lower zone, and it was infective etiology. HRCT similarly said that she was managed with antibiotic supportive therapy, and she was discharged with an ECOG status of 2. So this time, after having this malignant hypertension, the patient's family was counseled regarding the acalabrutinib, which had arrived by then to us post 1 year of ibrutinib, and then she was started on acalabrutinib 100 mg BD 1 week after her discharge. So 1 month post initiation of acalabrutinib, patient's BP was adequately controlled, continued to be in CHR. MRD was not done because they had refused for it. Patient was readmitted again after approximately 3 to 4 months with diarrhea and dyselectrolytemia in June 22. She was intubated in view of low GCS, developed ventilator-associated pneumonia after 5 days of intubation, and succumbed to her comorbidities, had a cardiac arrest as a terminal event. So this time, the cause of death was diarrhea, dyselectrolytemia, low GCS, BAP, following it BAP, and then the cardiac arrest. So this is how actually a patient of CLL may present with either with the comorbidities or with the side effects of the drug, and we need to take care. And since there are a number of drugs available to us now, we can have a permutation and combination of the therapies as per the comorbidities of the patient. So with this, are we done with chemoimmunotherapy in India? If we look into that, then you can see, yes, almost looking into the guidelines. However, in young patients less than 65 years of age, FCR, if the mutation status of IgHV is mutated and they do not have a TP53, then you can see that the blue graph over here is the ones which are bad. I'm so sorry. The blue lines over here, which have shown a very good PFS, and even in the German group, you can see that the mutated status of the IgHV has a very good response to FCR. So having said that, patients who are eligible definitely should be given a chance of FCR because it is a finite therapy, and the chances of having an MRD negative status is also high with the FCR regimen. So ibrutinib intolerance in the real world, if you look into, then the discontinuation rate approximately goes up to 42% after median follow-up of 17 months. Toxicity because of that drug, because it is to be taken for a long duration, it is approximately 50%. And disease progression, as we talked about, the kinase domain mutations are there, and it accounts for 10 to 20%. So progression-free survival has increased following the use of ibrutinib. The median PFS is approximately 36 months. However, the reasons for discontinuation most frequently are because of arthralgia, atrial fibrillation, and sometimes rash, which is seen in some of the patients. So with that ibrutinib, with the adverse events we saw with the ibrutinib, in acalabrutinib, the adverse events remain almost the same. Infection rates are 53% with 5% pneumonitis of more than grade 3%, some amount of bleeding, bruising, but less than that of ibrutinib, and cardiac events are relatively also less. So in this patient, when she succumbed, it was because of diarrhea, but we cannot attribute whether it was all because of acalabrutinib or she had diarrhea following some viral infection or a meal taken outside. So side effects of available BTK inhibitors, as we can see over here, the comparison between the two molecules, it is relatively much less in acalabrutinib as compared to ibrutinib. And since the cardiac risk factors, patients with cardiac risk factors and those who have had history of previous bad pneumonia or atrial fibrillation, a better way to go about is acalabrutinib rather than ibrutinib. However, atrial fibrillation is not an absolute indication to discontinue the protein kinase inhibitors. Again, anticoagulation should be used with caution because these two molecules have some amount of bleeding events associated with their use. So dosing guidance for acalabrutinib, it is 100 milligram twice daily, taken with or without food. If a dose is missed by more than 3 hours, skip that dose and take the next one at regularly scheduled time. There are some drug-drug interactions with the CYP3A inhibitors and inducers, and therefore it needs to be carefully administered in those patients. So after that, we come to the second case. It is a 65-year-old male presented with generalized lymphadenopathy, progressively increasing in size over 1.5 years with mild weakness for last 1 month. You can see the hemoglobin over here is 8.9, TLC 2.1 lakhs per cubic millimeter, TPC is 1.2 lakhs, and there is a lymphocyte predominance of 88. Did the next investigations like flow, iron, vitamin B12, and the DCT, all where the flow cytometer was suggestive of CLL. Looked into it, it was a Binet stage C in view of low hemoglobin. IgHV status was mutated, FISH panel, deletion 17p absent. So these were the reports of the patient. And looking into it again, the CLL first-line therapy, we could have gone for an ibrutinib, acalabrutinib, but then the patient opted for bendamustine rituximab regimen, and since he met the criteria of genetic mutations which were in favor of having a chemoimmunotherapy, this patient was given bendamustine rituximab in view of his age, no comorbidities, the status, logistics, and the fixed duration of therapy. So in the next case, it is again an elderly male, 72-year, history of coronary artery disease, underwent PTCA in 2019 with 3 stents in situ, type 2 diabetes, and hyperlipidemia. So you can see that most of the patients have the following illness in common. Routine checkup, hemoglobin is 12, TLC is 56,000, and the TPC is 60,000 with a lymphocyte of 92. No peripheral palpable lymphadenopathy, but spleen is 5 centimeter palpable. ECOG is 1, no B symptoms. Refer to hematology for opinion. You can see the status is unmutated for IgHV, and the TP53, there is no relevant mutation identified. So at this point of time, we had both the drugs available with us, ibrutinib as well as acalabrutinib. So regarding how to choose, here as the patient had some comorbidities, cardiac comorbidities, with the atrial fibrillation, hypertension, bleeding, which is higher with the ibrutinib as versus the acalabrutinib we discussed, this patient was started on acalabrutinib as per the ELEVATE-TN trial, which was a head-to-head trial with ibrutinib and acalabrutinib. And it showed that the acalabrutinib molecule had lower incidence of all the adverse events related to the cardiovascular toxicities. So this is the next case is in a relapsed CLL setting, the use of the drug acalabrutinib. So this was a 60-year-old male gentleman diagnosed as CLL Binet stage C in 2019, April 2019. So he received 6 cycles of BR outside somewhere else and had completed it by September 2019. He again relapsed in May 2022. I'm so sorry, it's not 8 months later, from 19 till May 2022. So repeat flow cytometer for the CLPD from the peripheral blood was again suggestive of CLL. 2D echo showed severe left ventricle systolic dysfunction with an ejection fraction of 37%. Cardiac evaluation done at our end showed he had dilated cardiomyopathy with a low ejection fraction. So if we look into the CLL update 2022 and also the NCCN guidelines, the second line of therapy, that means response to first line therapy, refractory or progress within 3 years, the next way to go is venetoclax rituximab, Bruton kinase inhibitors, other options being idelalisib rituximab and FCR. Idelalisib is not available with us in India, and I think the drug is less tolerable as compared to the Bruton kinase inhibitors. So for this patient, we started the patient on acalabrutinib, and if you look at right from May 22 till now, the patient had a very good increment in hemoglobin level, and 8.3 right at the starting, 8.3, 6.5, which was his presenting hemoglobin level. He has now reached a hemoglobin level of 13.4. Similarly, his presenting TLC count was 219,000 at the outset, and now presently he has achieved a CHR since January and continues to be having so. Platelet counts have remained stable throughout this time. So TLC trend, as we know that there is lymphocytosis, but as opposed for this acalabrutinib patients in our experience, we have found that the TLC count, the TLC or the lymphocytosis which we expect is not as much high as has been our experience with ibrutinib. It has there is a decline in the lymphocyte count as well as the TLC count over time, and it does take time to stabilize. So here you can see the hemoglobin trend, how beautifully it has moved up and then it has reached a plateau. So presently the patient is doing well with a hemoglobin of 13.5. So this is possibly my last case, and it is on mantle cell lymphoma, where we again have used ibrutinib and then switched over to acalabrutinib, and this is how the patient presented with us in March 2020. He's a 67-year-old male, presented with low-grade fever, loss of appetite, left upper quadrant heaviness for 15 days. And he had anemia, leukocytosis with relative lymphocytosis in the peripheral blood, had a massive spleen of 17 centimeter palpable below the left costal margin, no hepatomegaly or lymphadenopathy. Bone marrow study showed 65% atypical lymphoid cells, query mantle cell lymphoma. Flow cytometer done in 2020 again was positive for CD19-20 with surface immunoglobulin lambda restriction, FMC7 and CD38 were positive. IHC marker cyclin D1, SOX11 positive, KI of 80%. Conventional cytogenetics 46XY, translocation negative for the mantle cell, 2D echo, very good ejection fraction with a trivial TR. CBC again had persistence of lymphocytosis. The TLC count was 20,000, and the total platelet count was 192,000. PET scan showed that there were multiple nodes on either sides of the diaphragm with a splenomegaly and marrow involvement. It was a stage 4 disease, and he was finally diagnosed as mantle cell lymphoma leukemia stage 4. MIPI score was 3.5 intermediate risk, and he had a very good performance status 0 to 1. So this was the PET scan, which showed metabolically active lesions on both sides of diaphragm. Started on management 67 years. So he was started on injection bendamustine and rituximab. First cycle in March 20 had hypersensitivity reactions to first dose of rituximab, however managed well. Second cycle, he had febrile neutropenia following chemotherapy, and in view of COVID pandemic, as well as raised procalcitonin, he was just given rituximab and bendamustine was omitted. Third cycle, he was asymptomatic with the COVID, and third cycle, we again restarted with bendamustine rituximab, which he had tolerated without any complications. After third cycle, an interim PET was done, which showed partial metabolic response with some mediastinal lymph node having Duvall score of 4. And there was significant reduction in the other node size as well as splenomegaly. Aracy was added in the fourth cycle, and RBAC regimen, that is rituximab, bendamustine, as well as Aracy of 500 milligram per meter square was given. continued for 5th and the 6th cycle respectively, had again COVID-19 infection, but remained asymptomatic this time prior to the 6th cycle, and his therapy was deferred by a few days. So ultimately, he completed his therapy in September of 2020. Post 6 cycles, end of therapy PET was done, and it showed stable disease. Duval score 4 still remained with some of the retroperitoneal lymph nodes, and the impression was stable disease. So here you can see some of the nodes still remaining, and therefore we had to give him something, and COVID was going on. Patient has been infected twice. The patient was then started on ibrutinib 140 milligram, 2 capsules initially, and then escalated to 560 milligram OD after 1.5 months. So following 6 months, he had persistently low TLC. So in this case, because he was partially treated, his TLC count never went up with the lymphocytosis. It had been persistently low. Hence, dose reduced to 2 caps OD apart from the 4 caps daily. And he also noticed easy bruisability during this time, on and off GI disturbances. So apart from this, after following that in 2020 till now, in July 22, when he had his last visit or a last PET done, there was a complete metabolic response, and the patient had been tolerating this 2 capsules OD dose of ibrutinib for approximately 2 years. Patient was then counseled regarding switching to acalabrutinib in view of his on and off GI intolerances. And since the patient was in complete metabolic response at this reduced tolerable dose, was there a role at all of a second generation BTKI? That was even again a question. But then since the patient was having, he was annoyed with the GI disturbances, therefore we had thought of switching him over to acalabrutinib. So if we look into the guidelines again, the mantle cell lymphoma, there is aggressive therapy and less aggressive therapy. For aggressive therapy, we prefer the following regimens like RCHOP, RTAP, alternative regimen, hyperCVAD. And for the less aggressive therapy in elderly patients who are more than 65, we go for a bendamustine rituximab based therapy mostly. And then there is a consolidation for aggressive therapy with the ASCT or maintenance with the rituximab for elderly patients with rituximab maintenance every 8 weeks for 2 to 3 years. So with this, if the patient has a partial response, that was the best option available to us that the patient had at the time of COVID, and we had changed the patient over to ibrutinib. So in the second line therapy, you can see even for patients on mantle cell lymphoma, the preferred regimens are not the chemoimmunotherapy, but the BTK inhibitors of the small molecules. And also there is an option for rituximab and lenalidomide. So this was a summary of the treatment for our patients. So with those real world experiences we had for our patients and the others who have been on acalabrutinib, it had been a quite smooth journey for them. We now discuss regarding a little bit of what the trials have said us, like the Elevate TN, which was the treatment naive patients, therapy naive patients of CLL, a 5-year follow-up. If you look into that, then the PFS is good with the acalabrutinib obinutuzumab or the acalabrutinib single agent as opposed to obinutuzumab and the chlorambucil chemoimmunotherapy arm. So here you can see both the arms, the PFS is much better than this line which is in blue representing the obinutuzumab and the chlorambucil arm. Similarly here, whether irrespective of whether the patient is DEL 17P and the mutation of the TP53 status, you can see that the acalabrutinib, whenever it is given in combination with obinutuzumab or alone, has a better PFS as compared with the chemoimmunotherapy arm. Similarly, for whether it is mutated or unmutated IGHV, it remains the same, a favorable graph towards acalabrutinib. And if we look into the events, the safety events, then we can find here that cardiac events, atrial fibrillation, bleeding. These are the most common adverse events of the drug. However, their incidence of more than grade 3 is relatively much less, and they can be managed. And if the patient has more than grade 3 cardiac events of bleeding, then it is we have to give a thought whether we can continue the drug and switch over to something or some other options which is available to us. Similarly, in the ASCENT trial, acalabrutinib versus rituximab plus idelalisib or bendamustine in the relapsed refractory CLL, It is again a 4-year follow-up data, and here again they have shown that the median PFS has been better with the acalabrutinib arm as opposed to rituximab in combination with bendamustine and idelalisib. Similarly, deletion 17p, IGF mutation status, which are the two most important things we need to determine when we are starting a therapy for a patient on CLL. This has showed that across all the arms, there has been a better median PFS with acalabrutinib as opposed to the idelalisib arms. So incidence of events, again, the same over here. And there was even a head-to-head trial of acalabrutinib versus ibrutinib regarding these three main adverse events which are seen. And you can see there is a gap between the acalabrutinib and ibrutinib. That means this is the ibrutinib arm and this is the acalabrutinib arm. The bleeding events are significantly less with the acalabrutinib arm as compared to the ibrutinib across bleeding events, diarrhea, as well as arthralgia. So something we want to look into, those were regarding the trials and acalabrutinib in the real world evidence in CLL and treatment patterns. You can see that in the real world, actually, the amount of the response or the side effects with the acalabrutinib has been almost the same, which was seen in the trials. So approximately 1/3 of the MCL patient and 2/3 of the CLL patients initiated with acalabrutinib had prior treatment with BTK inhibitor. They had a better tolerability, and the median duration of the treatment was approximately 10 months. So with the antiarrhythmic agents, with arrhythmic agents, anticoagulants, antihistaminics, still you can continue to give the therapy, and the side effects are very well controlled even at the minimal doses of the therapies which you are giving as a elevator for the to alleviate the side effects. So toxicities and outcomes of acalabrutinib treated patients with CLL, it was again a retrospective analysis from the real world. And what they have said is, overall, the acalabrutinib DC rate was 19% in the study. Discontinuation rate secondary to adverse events was similar to the clinical trial data. So even in the real world data, it has not showed an increased amount of fallout that the patients have not dropped the treatment of acalabrutinib as opposed to ibrutinib, where there was a discrepancy between the clinical trials and in the real world evidence. So these are a few of my concluding slides where we have 3 available covalent protein kinase inhibitors, ibrutinib, acalabrutinib, and zanubrutinib, which is US FDA approved, but zanubrutinib is not available with us. We have ibrutinib and acalabrutinib. Some points to ponder: BTKIs and the infections. How do we manage? Do we stop? When to restart and when to permanently discontinue? We had few questions of this when we were treating our patients. Viral infections, whether seasonal or COVID or bacterial infection or fungal infection or tuberculosis, which is quite rampant in India, as well as other atypical infection, whether we need to stop or we continue therapy of BTKIs. And do we prophylactically give antimicrobial for these patients still remains a question in our setting, because there is high amount of infections in the prevalent in India. And there are some other specific questions to BTKIs, like the frontline therapy for patients who are fit, go-go type, whether we should continue with the first-line BTKI or we should consider FCR. Contraindications for BTKIs, like we have many patients who are on anticoagulants with atrial fibrillation and all, warfarin, for whom warfarin is to be indicated. In those cases, DOACs are okay, but then we are not able to give warfarin along with ibrutinib or acalabrutinib. Severe life-threatening cardiac issues are a consideration for this small molecule. Aspirin is okay, but then dual platelet inhibitor are again plus minus, probably okay, but you may not preferably go with a dual platelet inhibitor in patients who are on BTKIs. And pre-existing atrial fibrillation, though literature say it's okay, but practically when we go to prescribe a patient, we definitely have a second thought whether we should go for a BTKI or we should go for venetoclax. So there are some, these questions still remain unanswered. And for some, how long to wait to switch from a BTKI to another drug? It has been seen that there is rapid progression of CLL on stopping BTKI and resulting progression of the disease. So consider continuing BTK therapy temporarily while continues to rise over time, as well as some other cardiac risks with ibrutinib, but it has not been seen with acalabrutinib. Although shorter follow-up, but still acalabrutinib seems to be a better molecule as compared to ibrutinib. So, concluding, covalent BTKIs are all effective and tolerable oral agents. Pros and cons to all the agents remain. The second generation BTKIs appear less toxic. They can be used without anti-CD20 therapy and TLS monitoring, so the patient can take it right away at home. Hence, a preferred choice for patients requiring upfront therapy for CLL. Some things to ponder about in the future: combination approaches like BTKIs with venetoclax or obinutuzumab may improve the outcome as compared to the single agent continuous strategies, as these combination therapies may have a 2-year or a limited time duration of therapy. What is the optimal duration of therapy still needs to be determined with the follow-up data, so that we can even know the not only the efficacy but also the tolerability of the drugs. Whether this duration should be guided by assessment of MRD remains a question, because till now MRD is not a guideline to look into when we assess the response to the therapy, and ultimately decision should be made on a case-by-case basis for individual patients based on their disease comorbidities and unique circumstances. Thank you.
Thank you so much, Dr. Priyanka, for a lovely lecture and a wonderful case discussions. Please do hang out with us. We'll have a discussion at the end after Dr. Elena Gary's lecture. Let me share the screen again.
Sure, thank you.
Now moving to the second lecture for the day by our guest speaker, Dr. Elena Gary from Vancouver, Canada. Dr. Elena Gary is Assistant Professor, Hematology and Oncology at Center for Lymphoid Cancer, BC Cancer, University of British Columbia, Vancouver. She's a hematologist and assistant professor in the Division of Hematology and Medical Oncology at the University of British Columbia, and a clinical investigator at the Center for Lymphoid Cancer at BC Cancer in Vancouver, Canada. She completed her medical degree and internal medicine residency at the University of Toronto, followed by a hematology and bone marrow transplant fellowship at the University of British Columbia. She earned a Master's of Public Health degree from Harvard University, where her research included investigating the impact of genetic abnormalities on population-level outcomes in chronic lymphocytic leukemia. Her other academic interests include the investigation of novel therapeutics and cellular therapy for CLL and lymphoma. She is a member of the Canadian Steering Committee for National CLL Treatment Guidelines and is a member of the International Workshop on CLL Global Partnership Subcommittee, which aims to improve outcomes of CLL patients globally by supporting clinical and research training and local capacity building. She is going to lecture us today on chronic lymphocytic leukemia and update. Well, thank you so much. Over to you, Professor Dr. Elena Gary.
Yes, thank you very much. Thanks for that kind introduction, and thank you very much to the Mumbai Hematology Group for inviting me to speak here today. I'm just going to try to share my slides. Something funny just happened with my computer. 1 second.
Sure.
I just have to reopen my file here. Okay, I think I've got it. Sorry about that. There, can you see the slides here now?
Absolutely perfect.
Okay, great. And I just wanted to share a very unique connection. My mother is from India, and she's Parsi from Mumbai. And when I was first asked to do this talk, I agreed. I was thrilled to be able to speak with this group. And then I noticed the address of the Mumbai Hematology Group on your website, and it says it's in the Hematology Center in the Gamut Lodge in Dadar, Mumbai. My mother's surname is Gamut, and before even she was alive, previously her family home was in Dadar. So I was very intrigued by this and just wanted to share that connection with you all. And I'm going to, as mentioned, I will be speaking about chronic lymphocytic leukemia. There'll be some overlap with that excellent previous talk you just heard, and maybe I can go through some of those slides more quickly, but I think it'll be a great discussion for us at the end. I do have disclosures. I've received institutional research funding and participated in advisory boards and received honoraria from the companies listed here, primarily related to CLL, clinical trials, and drug development. So in terms of objectives, I'm going to focus really on the emerging data and pivotal trials of novel agents, primarily in first-line CLL. That's where a lot of the action has been over the last few years. And, I do want to state, I recognize that some of these treatments are not available. I'd be very interested to hear afterwards, what you may be able to access or not. I just heard zanubrutinib is not accessible. But nevertheless, I will talk about the new drugs coming down the line, as I'm sure over time you will have increased access to these. I'll compare the toxicity profiles between treatment strategies, highlight strategies to help choose between novel agents, and discuss a practical risk-adapted algorithm for CLL therapy that we've developed here in British Columbia, and examine just briefly what else is coming down the pipeline. And just to start, I wanted to just bring up the CLL epidemiology, which I know that your group is, I'm sure, very well aware of. Certainly in Western countries, and Canada is very similar to the United States. I don't have Canadian specific data in this particular table, but CLL is the most common leukemia that we see. And the incidence is approximately 3.3 per 100,000. It makes up nearly 30% of all leukemias, with a prevalence, at least in the United States, of about 67,000. Canada is about a tenth of that, so about 7,000 for us. Whereas for you, the prevalence is certainly much lower, only 4.3% of all leukemias. And the prevalence only about 10,000 in 1 year, which for your population is quite small. So I'd be really curious at the end to just hear in general how many CLL patients you have coming through your clinics. And certainly for me, I do see a lot of CLL. So I too will start with a case. This is a patient of mine, a 63-year-old gentleman who was diagnosed with Ry stage 2 CLL a few years ago. But then when I saw him more recently, he was having progressive lymphadenopathy, cervical and axillary. He had splenomegaly on exam. He had some minor non-drenching sweats, a 10-pound weight loss, which was less than 10%. And fatigue. His blood counts were actually quite good, lymphocytes 30 only, and normal hemoglobin and platelets. And beta-2 microglobulin was normal. His FISH panel was normal, no deletion 17p. We do not have routine testing for TP53 yet that's publicly funded in British Columbia, and we're hoping that will come within the next year. But he did have an IGHV mutational status test and was unmutated. So I think the first big questions with CLL still remain, when do we treat patients? And then, of course, what to treat with. So there's a number of different prognostic scores out there for CLL. This one, I would say the CLL IPI seems to be the one gaining the most traction. It's now used in some clinical trials, and it's also very practical. The majority of the tests are easily available. Actually, we didn't have IGHV mutational status until a few years ago. That was funded. We were able to get it from private pay, but and we still don't have TP53, but we essentially have the other markers on this prognostic score. So for this patient, he would get 1 score for being Ry stage 2, 2 points for being unmutated, so a total score of 3. So he's really in that intermediate risk group. He has an excellent 5-year overall survival. And sometimes these intermediate patients are the ones that are a little bit harder to think about what we might treat them with. In terms of the first question of when to initiate treatment, we know that we only treat when there's active disease, not based on a lymphocyte count. Of course, this can be very anxiety provoking for patients, knowing they have lymphocyte counts in the hundreds, but it's not an indication to treat. And according to the International Workshop on CLL, the IWCLL treatment guidelines, which actually have not been updated since 2018, but there really is no change in these recommendations. We only treat when patients have symptoms, such as the ones listed here. So progressive marrow failure, Rye stage 3 or 4, symptomatic disease, progressive lymphocytosis with a doubling time approximately less than 6 months, autoimmune complications that aren't responding to standard treatment, or fairly significant disease-related symptoms interfering with their ability to conduct normal activities. This has sort of been called into question, though, now that we have better treatments for CLL. A number of groups have looked at, should we be treating patients earlier? Should we be treating them at diagnosis? And we recently published our Canadian frontline treatment guidelines, and we sort of looked at this question again just to see if there's any change in these potential recommendations. And there's been 2 main studies that have been completed so far that looked at asymptomatic but high-risk CLL patients. One used a German CLL score, and the other used a different sort of 8 different factors. And the first one looked at FCR versus observation. And certainly I would be concerned with giving an asymptomatic patient FCR. They did actually show a significant improvement in event-free survival, but there was no difference in overall survival at 5 years. And really, it was not felt to justify use of FCR. Well, what about a less toxic treatment? So giving ibrutinib regularly versus observation. And again, they did see a significant improvement in event-free survival with not reached in the ibrutinib group versus about 4 years in the observation group. However, again, there was toxicity and it wasn't felt to be enough to change this overall recommendation. There are a number of studies that are currently ongoing, and just highlight this EVOLVE trial. So this is a SWOG study that also our Canadian Clinical Trials Group is participating in. These studies, both this one and the Mayo Clinic study, are using the CLL IPI risk score. And for patients who have high risk CLL IPI, they're actually comparing them, so in the EVOLVE study, comparing them to early treatment, so treatment right away, with venetoclax obinutuzumab. So this is somewhat attractive because it's a time-limited regimen of only 1 year versus the typical delaying it until they become symptomatic. So, I think we have to keep our eye open for this. This whole mantra of treating only once symptomatic may change over time, but for now that it's still certainly the recommendations. So then moving on to what to treat with. So this is our gentleman, 63 years old. I didn't tell you, but he essentially doesn't have any comorbidities. He is a smoker and has some emphysema on his CT scan, but isn't really symptomatic. Normal fish, unmutated IgHV. So here are some options: chemoimmunotherapy with FCR, bendamustine rituximab, and then we get into the novel agents: ibrutinib plus or minus obinutuzumab. You saw some of that data in the Elevate-TN trial that was just presented. Zanubrutinib, or venetoclax obinutuzumab, which again is that time-limited therapy. So perhaps just think about that as we go through, and we'll come back to this case at the end, and then I'll tell you what I ended up doing. So there's certainly been a major change in the treatment landscape of CLL over the last 10 years. At first, there was really the recognition that adding rituximab to chemotherapy improved outcomes, and we have our standard regimens. We actually used to use a lot of FR without cyclophosphamide in British Columbia, and we had quite good outcomes with that, BR or chlorambucil obinutuzumab. Then we were into the era of the new targeted agents, BTK inhibitors. Ibrutinib was the first one to come along. There was a brief stint with PI3 kinase inhibitors. We did have it available in Canada. It was hardly used, a lot of toxicity, really fallen out of favor now. Then we got into venetoclax monotherapy, primarily for relapse disease, the second generation BTK inhibitors, Acala and Zanu. And now we're entering an era of non-covalent BTK inhibitors, pirtobrutinib and nemtabrutinib. These are not yet funded or even approved in Canada or by the FDA, but certainly they're coming down the pipeline. And I think where we're really heading is this idea of combination therapy or time-limited therapy. So ibrutinib with obin or Acala with obin, those are still given indefinitely, but combination of Ven-O is given for 12 months, And now people are looking at the triple combinations of BTK inhibitor, venetoclax, and the CD20 monoclonal antibody. So I'm going to first talk about the BTK inhibitors. And as you're aware, the different covalent BTK inhibitors have many off-target effects, and we heard about some of those. And those are really what drive the toxicity and the intolerance to these drugs. So here are the three main covalent BTK inhibitors. And this is a map of a kinome. So all the different kinases in the body, BTK, Bruton tyrosine kinase, sits somewhere around here. And you can see that ibrutinib certainly targets BTK, but it also targets many other kinases. And that's what's felt to be responsible for a lot of its toxicity. Acalabrutinib is much more specific for BTK, and zanubrutinib perhaps somewhere in the middle. And then here I've listed all the sort of the major clinical trials that have led to the approvals for these drugs in both the first-line treatment naive and relapse refractory setting. And then some important trials, although they didn't lead to approvals, some of the most important trials we have with these drugs. For ibrutinib, in the first-line setting, there's two big trials that compared ibrutinib to chemoimmunotherapy, and I'll speak about one of them. And then for acalabrutinib in the relapse setting, there was a really important trial comparing it to ibrutinib. So, is chemoimmunotherapy dead? I know that was a question that was asked in the previous talk, and we still struggle with this question here in Canada as well. We still do use chemoimmunotherapy. So this trial is particularly important. This was the ECOG 1912 trial. It was recently about a year ago, was updated in Blood. This took first-line patients. They had to be under 70, so a bit older than what we usually use 65 as a cutoff for FCR. Their creatinine clearance 40 or greater, and they had no deletion 17p. They were randomized to ibrutinib plus rituximab. Their R was only given for 6 cycles. Ibrutinib was given indefinitely versus standard dosing of FCR. And as mentioned, the ibrutinib was given until progressive disease. We now know that there's really no benefit to adding rituximab to ibrutinib in other clinical trials. And so this has really fallen out of favor. So you can think of this as a main comparison of ibrutinib to FCR. And here's their 5-year updated data. At 5 years, the progression-free survival was significantly improved in the ibrutinib group when looking at all comers, with 5-year survival of 78% versus 51% with FCR. And what was really intriguing with this study is that there was actually an overall survival benefit with ibrutinib compared to FCR. And when that first came out, I think people thought, oh, it must be because people were dying of toxicity from FCR. But in fact, when you look at the causes of death, it's actually CLL progression in the FCR arm that seems to be the main cause of death. So it's not toxicity. When we look at this comparing the unmutated to mutated cases, you can see that it's the unmutated cases where this is what's really driving the difference. Ibrutinib significantly outperforms chemoimmunotherapy in the unmutated cases, 75% versus 33%. But what's interesting is in the mutated cases, there was always this idea that there was no difference between chemoimmunotherapy and BTK inhibitors. And a lot of that data was because there was early follow-up, sort of 3-year follow-up. And remember, these are subgroup analyses, so there's always small numbers when looking at these subgroups. And these mutated patients do well. So we know it's going to take a long time if we're going to see a difference. And what's interesting about this 5-year follow-up is that there actually has emerged a significant difference in progression-free survival between ibrutinib still outperforming FCR, even in mutated patients. So this is sort of relatively new data, given that it took 5 years to get this type of follow-up. There's still no difference in overall survival. And still in Canada, FCR is the only funded available option for mutated, younger, fit patients. But I think this kind of data is going to shift that over time. And at least now we know that ibrutinib is a good option for these patients and potentially is better, at least in terms of progression-free survival. So now moving on to acalabrutinib, we already saw this data very nicely presented. In the frontline setting, the Elevate treatment naive trial compared acalabrutinib with obinutuzumab, that's the top curve, versus acala monotherapy versus chlorambucil obinutuzumab. So obviously a striking difference between chlorambucil obin. And there is a significant difference with the addition of obinutuzumab in terms of progression-free survival. It's about an 11% difference here. It is statistically significant. However, there was increased toxicity with the addition of obin, more neutropenia, infusional reactions. And I think there's, it's questionable whether people feel this is a clinically relevant difference. In Canada, most provinces do not have access to obinutuzumab with acalabrutinib, so most of us are using acalabrutinib alone. And then, as you heard, in a relapse setting, the ASCEND trial showed that acala monotherapy was better than BR or Idelawar. So getting to the really interesting trials of the head-to-head comparisons with BTK inhibitors. And this was the acala trial. And what's important to note is that this trial was started quite some time ago. And at that time, the group that was entered, they had to have high-risk disease only, deletion 17p or 11q. They had to be relapsed, but the majority of the patients had actually had a number of prior lines of therapy. The median was 2, the range was up to 10. So it is a very heavily pretreated high-risk group. Looking at the curves, acalabrutinib was non-inferior to ibrutinib. The curves actually lie completely on top of each other. The median PFS is the exact same in both groups, and the hazard ratio is 1.0. So essentially, these are the same efficacy, and the median survival has not been reached. Where the interesting part is, of course, is with the toxicity. So this is looking at acalabrutinib toxicity versus ibrutinib. And the main driving difference is the differences in cardiac events and atrial fibrillation. So at this follow-up, I believe this was the 3-year follow-up, the ibrutinib group had about 16% AFib versus 9% with acala. There was an episode of VTAC with ibrutinib, which we do see this kind of signal of cardiac deaths with ibrutinib is emerging as more and more patients are treated. There was a significant difference in hypertension, 23% with ibrutinib, 9% with acalabrutinib. Not really a major difference in bleeding events or infections. I certainly was hoping there was going to be more of a difference, but you can see, 51 versus almost 40% here. Bleeding was about the same, 5 versus 4.5 for major, and infections about the same, 80%. But overall, there were fewer treatment-related discontinuations with acalabrutinib at about 14%, 15% versus ibrutinib at 22%. And we see this in clinical practice. For us, we've looked at our outcomes of ibrutinib in the real world, and we too, like the American data, see about 40% treatment discontinuation over time. And with acalabrutinib, just anecdotally, I certainly find it is better tolerated and less patients need to discontinue. So moving on to the next covalent BTK inhibitor, which is zanubrutinib, that's coming now approved and not yet funded in Canada, but going through the funding mechanisms. And we do have a compassionate access program where we can access it. So there was a very interesting study, again, doing a direct head-to-head comparison of zanubrutinib to ibrutinib. And again, although it seems like a similar population to the acalabrutinib trial, this was all relapse refractory patients. They didn't have to have del-17p or 11q. And they were relapsed after one prior line, and the majority of patients only had one prior line. This study was done later, more recently, and they weren't as heavily pretreated as the other study. And what was really surprising and actually quite remarkable, and this was just presented as a late-breaking abstract at ASH this year and published in the New England, last year, there was actually significant improvement in progression-free survival with zanubrutinib compared to ibrutinib. So sort of questioning this idea that all covalent BTK inhibitors are equivalent. So the difference was about 13% with a hazard ratio of 0.65. And there was some preclinical data to suggest why this may be. Zanubrutinib was specifically formulated to have better, more selective for BTK inhibitor, and also to have better BTK occupancy and stay above the kind of IC50 dosing threshold more often than ibrutinib. So there's maybe some reasons. Again, where a really important difference was seen was in toxicity, primarily cardiac events. And you can see that serious cardiac events were almost 8% with ibrutinib compared to 2% with Zanu. And here are the 6 cases of serious cardiac events with zanubrutinib. But really what was interesting is that there was actually a number of fatal cardiac events with ibrutinib, 6 versus 0 with zanubrutinib. This 6 is quite high compared to what's been seen in other ibrutinib trials. But again, this signal of cardiac deaths with ibrutinib is really emerging. Here's a graphical example of the cumulative incidence of atrial fibrillation and flutter, about 5% with zanubrutinib versus 5% with zanubrutinib versus 13% with ibrutinib. So again, putting all this data together, both the Acala data and the Zanu data, it really is felt the 2nd generation BTK inhibitors are safer, particularly in terms of cardiac events, and then of course with that concern of cardiac death. So for us, where we do have funding now for Acala, we're waiting for zanubrutinib, we are really hardly using ibrutinib anymore. So I think anytime we can use a 2nd generation BTK inhibitor, we would over ibrutinib. All right, I'm going to shift gears and talk about venetoclax-based therapy. And I actually don't know if you have availability to venetoclax or have experience with venetoclax. We're just gaining our experience with venetoclax now, primarily based on this trial. So this is in the frontline setting, the CLL14 trial. And they took patients, there was no age, it wasn't based on age, it was based on comorbidity score, so SIRS score greater than 6 or creatinine clearance less than 70. And they compared 12 cycles of venetoclax with obinutuzumab given for 6 monthly doses, compared to chlorambucil obinutuzumab. And just to point out that venetoclax, there is the ramp up, I'll show a schematic of that. So that actually doesn't start until partway through cycle 1. Because patients actually start with the obinutuzumab first. So they get the obin on cycle 1, day 1 and day 2, kind of a priming dose and then the main dose. And then they get it on day 8 and 15. And then from cycle 2 onwards, it's just once a month. So it is sort of intensive, 4 infusions in cycle 1, but then just once a month after that. And then you have the ramp up that starts in cycle 1 as well. So as you guys are likely aware, venetoclax has a very high risk of, well, it works so well. So it can really induce tumor lysis syndrome very quickly. And so therefore this really slow dose ramp up has been created to help mitigate the risk of tumor lysis syndrome. Patients start at 20 milligrams for 1 week, and then it goes up to 50 for week 2, 100, 200, up to the target dose of 400. They have to have prophylaxis with allopurinol or even rasburicase if they're high risk of TLS. There's specific ways to classify patients as low, medium, or high risk for TLS. And patients considered high risk with high tumor burden actually are recommended to be hospitalized for the 20 milligram and 50 milligram dose increases, because they should have intravenous fluids, and we need those frequent laboratory monitoring. So even as an outpatient, that we do have a very detailed protocol that shows exactly when they need to get their blood work, and we still do it at 6 hours post-dose. So they take their drug at 6 a.m., they get their labs at noon, and then at 24 hours post-dose the next day. And they don't take their day 2 dose until we give someone checks their blood work. We call them and say, okay, you can go ahead and take your dose. And then they need to get blood work again prior to their next dose, the next weekly ramp up. And we do the whole thing again. We do blood work at 6 hours, 24 hours, and then they get a call. And then for as long as the first 2 weeks have gone okay, then the blood work slows down a little bit, but really it's quite intensive for these first 5 weeks. Once they're on the full dose venetoclax and the obin is now just once a month, it's generally quite smooth sailing. And I would say that patients do very well once they're at that point, but it's those first 5 weeks. I actually tell patients that this is a commitment for the first 5 weeks. It's quite involved, but then it will get much easier. And the benefit is that it's only for 12 months. Oh, and I just put here, we do have in our BC Cancer website, we do have our protocols for venetoclax therapy, which do have a lot of information on, all the dosing recommendations. Of course, you can also get that from the drug monographs and company provided materials. So what are the results? Well, this is a recent publication in Nature Communications of the 5-year follow-up. So at 5 years, the PFS for Ven-O was 63% versus 27% for chlorambucil. This is in all comers, and there's no significant difference in overall survival at this point. However, again, the more interesting thing is how does this break down by risk factors? So looking at mutational status, the mutated patients doing extremely well, 75 or 80% 5-year PFS. It is significantly better than the unmutated, where their 5-year PFS is about 56%. But to me, this is still a really excellent 5-year PFS. And remember, 5 years means they've been off drug for 4 years. So they've been on nothing for 4 years, which is really fantastic for these patients to have that kind of a treatment break. For deletion 17p, the story is a little bit different. At 5 years without del 17p, the median PFS is 66%, and at 5 years with, it's 35%. So, you know, it is quite significantly different. It is quite low. We don't have great options for these patients. So this kind of data, you know, has led people to think, well, how does this compare to giving a BTK inhibitor? So if at 5 years with this regimen, the PFS is 35%. So with BTK inhibitors, one of the longest follow-up of frontline BTK inhibitor for deletion 17p was this phase 2 trial run out of the NIH. And they've published their long-term follow-up at 6 years, where the progression-free survival for these are patients with del 17p is 60%, which is fantastic. So that's compared to the 5-year PFS of 35% with Ven-O. So with this kind of comparative data, and recognizing we're not supposed to compare trials, but overall the feeling is that BTK inhibitor monotherapy continuous treatment is better than time-limited treatment with Ven-O for these very high-risk patients with del 17p. But for unmutated IGHV, I think it's for me, Ven-O time-limited therapy is still quite a reasonable option. And just quickly to mention, there is now data emerging about using Ven-O in younger patients. This was a really interesting trial that has just been published about a month ago in the New England. This is from the German CLL study group, and they looked at fit patients with CLL without del 17p. And they've compared chemoimmunotherapy, because we still have this question if we should be using chemoimmunotherapy for younger fit patients, to 3 different venetoclax-based regimens. The first one was combined with rituximab, the next one with obinutuzumab. So this is the Ven-O regimen I just talked about. And then they've got a triple combination with venetoclax, ibrutinib, and obinutuzumab. Their primary endpoint was looking at MRD. So if you look at the Ven-O group compared to the chemoimmunotherapy group, there's a significant improvement in MRD. And same if you look at the triple combination compared to chemoimmunotherapy. However, just eyeballing it, they didn't do a specific comparison, but there's not a huge difference between this triple combination and Ven-O. So this is certainly something people are interested in following. And if we look at the actual results, the progression-free survival, the triple combination is in the orange, Ven-O in the blue, and then Ven-R and chemoimmunotherapy down here. And kind of the upshot is that Ven-R is really no better than chemoimmunotherapy. So that one's kind of out. And then Ven-O or the triple combination are both significantly better than chemoimmunotherapy. And it's really not clear that there's going to be an emerging difference between these two arms. So do we really need the triple therapy is the question. And here is the same kind of data, just separating between unmutated patients, where again, that's what's driving that big difference between chemoimmunotherapy. But even in the mutated patients, they are doing better, although it's not statistically significantly improved compared to chemoimmunotherapy. So again, mutated chemoimmunotherapy, they still do quite well. So how do we choose between these upfront therapies? Let's take chemoimmunotherapy out for now. When we're thinking about novel agents, if we had access to both options, what are some of the pros and cons? Well, BTK inhibitor therapy is indefinite versus only 12 months for Ven-O. We've already talked about the efficacy. It's essentially comparable except for deletion 17p, where I think BTK inhibitors are favored. And then toxicities. You heard about a lot of the BTK inhibitor toxicities in the previous talk: bleeding, hypertension, AFib, GI, rash, infections. With Ven-O, it's really the infusional reactions with the obinutuzumab, and then the risk of tumor lysis. And we can see neutropenia, and I have been giving growth factors to some patients who had persistent neutropenia. There's comorbidities we want to think about. For Ven-O, really, it comes down to, there's not a lot of comorbidities I'd be worried about apart from renal insufficiency. It's more if people are frail, cognitive impairment, just inability to understand the need for all this blood work and the whole dose ramp up scheme. And then logistics is a huge factor. So obviously prescribing a BTK inhibitor is easy. It's a pill, they can take it, they go home and take it. With Veno, as I mentioned, the first 2 cycles are very involved, frequent labs, admission for high-risk patients. But then it does become very easy, and then they're done after 12 months. And to me, at least for us in North America, the cost is a huge difference between these 2 regimens. Indefinite BTK inhibitor therapy is extremely costly. And in Canada, which is a public healthcare system, we are going to break the bank if everybody's on indefinite BTK inhibitor therapy. So we really are trying to use Veno where it's appropriate. But again, the logistics can be challenging with that. So the final point I'll make about this, what about combining the 2 of these drugs? Well, actually the combination of ibrutinib venetoclax was just approved by Health Canada in March. And interestingly, it has not been approved by the FDA and may not be, I've heard, because of the increased toxicity with this regimen. But I'll just briefly show you, it was approved based on 2 main studies, the GLOW study, which was in the older patient population. And when these 2 regimens are combined, the standard, there's many different ways that have been looked at, but the standard way is to give ibrutinib for the first 3 cycles, kind of like a lead-in, and then to add in the venetoclax for 12 cycles. So it's a 15-week kind of program. And this GLOW study compared it to chlorambucil obinutuzumab. And then there's also a phase 2 study called Captivate out of the UK. This was more in the younger patient population. Under 70 years of age. And again, they did the 3 months of ibrutinib followed by the combination. So the results for GLOW at 4 years, this is what's been presented thus far. The combination of ibrutinib venetoclax, the 4-year PFS is about 75%. And if you remember back to our Ven-O, the 5-year PFS was about 66%. So again, it's not entirely clear that we need the double combination compared to each agent alone, but what is the benefit of this double combination is that it's an oral combination, so no IV infusions required, and it's time limited. Previously ibrutinib, anything with BTK inhibitors is monotherapy is indefinite. So now by adding in the Ven, you can give it as a time limited because you get these deeper responses. Also, by doing the ibrutinib lead-in, as expected, you do have a decrease in tumor lysis risk. So at baseline, about 25% of patients were considered high risk and would have needed admission. But by the time you do the lead-in, you're down to only about 2%. So really improving that group who might need admission for venetoclax. So what about toxicity? And this, I'm now looking at the Captivate data. Kind of the toxicities you may expect, but neutropenia is we see there's quite a bit of it. Arthralgias, hypertension, and then because ibrutinib is the BTK inhibitor here, we do see all these cardiac events, the bleeding, and there is concern about toxicity with this regimen. I think what will be more interesting is that as we combine venetoclax with the 2nd generation BTK inhibitors, we'll probably see less toxicity. So with all of that in the background, and I'll say that regimen, although it's Health Canada approved, it's not yet funded. And to be honest, I don't know that it'll meet the bar for funding by our payers based on that data. Because of the cost, the increased costs associated with the combination. So back to this case, the 63-year-old gentleman, relatively healthy, normal FISH and unmutated IGHV. These are the options that I was considering for him. In the end, we had a lot of discussion about BTK inhibitor therapy versus Ven-O. He actually lives in a small community. We weren't sure if they'd be able to do the Ven-O ramp up. They have general practitioners that follow the patients up there and give chemo with guidance from hematologists. So, but in the end, they were keen to try Ven-O and he wanted to do time-limited therapy. So that's what he's been started on. And so far, he's been tolerating it quite well. Here is an example of the algorithm that we've developed currently in British Columbia for CLL, first-line CLL treatment. First thing I always think about is whether patients have deletion 17p, and I'd like to consider TP53, but we don't have that yet, hopefully in the next year or so. If they do, we have access to the targeted therapies for these agents. And again, I would favor a second generation agent over ibrutinib. Ven-O is not wrong, but I think is not preferred in this very high risk group. If there's no del17P, we look at mutational status. If they're unmutated, again, we're into the targeted agents, but I've kind of moved Ven-O up higher because I would consider that in the majority of patients if we can get around the logistics concern. If they're mutated, then we look at fitness, age, comorbidity, creatinine clearance. If they're young and fit, as I mentioned, chemoimmunotherapy is our only available funded option. And we have very good data, long-term data with chemoimmunotherapy. I think it is a very good option for these patients. I do think there's other options coming down the line, well, that actually have good data for them, not yet funded for us, but probably soon. And then for the older or unfit patients, there's a mishmash of options. BR would be the chemoimmunotherapy I would prefer over chlorambucil obinutuzumab based on a lot of the data we've seen. And then second generation or BTK inhibitors or Ven-O. So I'll just end by talking about one other case. So this is what happens for treatment after BTK inhibitor and venetoclax therapy. Or if you weren't able to access venetoclax therapy, what are we going to do after patients progress on BTK inhibitor therapy? And this, I think, is really the unmet need right now. And we're going to start to see more and more of these patients coming through our clinics. So this is a patient of mine. She's 72. She had CLL diagnosed in 2010. She has high-risk features, del17P, IgH unmutated. She received treatment with FR, which was what our standard was. And this was well before we had targeted agents. So FR in 2011, then she relapsed, she got BR in 2014. And then we were able to start ibrutinib when a compassionate access program started for us in 2016. And when ibrutinib is all we had, or if it's all you have, we really do push it. So she had quite significant complications. She had a pseudomonal sepsis, but she paused it for a while, but then we had to get back on therapy. We just reduced the dose, we carried on. And then she started to slowly progress. But again, we actually didn't have any other treatments for her. So we just kind of monitored her, and it was quite a slow progression over about a year. And so finally, by August 2018, I was able to get venetoclax on a compassionate access program, and I convinced the government to add in rituximab, so they did fund that. So she got Ven-R, which is, I didn't talk about the Murano study, but that's where the data comes for venetoclax in the relapse setting. It's given for 2 years normally, but I was able to squeak out through the company program more venetoclax for her because I was very worried about stopping treatment given her high-risk disease. So she's been on venetoclax monotherapy for almost 3 years. She's had ongoing recurrent infections, so she's on monthly IVIG. I don't know if you guys, what kind of access you have to that. We're able to access it if someone has recurrent infections in the setting of low IgG levels. And then just earlier this year, she was clearly progressing, lymphocytosis, symptomatic lymphadenopathy, and significant fatigue and even sweat. So what was I thinking about now? Well, really all I have is repeat chemoimmunotherapy. Clearly not favored. She's already had 2 prior lines. She's at high risk of secondary malignancies, AML, MDS. I haven't given her cyclo before. I was thinking, is that an option? We still have Idela-R as an option, although significant toxicity with it. She was really not interested in that. We used to give alemtuzumab to these patients with del17P. The company has sort of stopped marketing it. They've moved on to this drug in MS, and that's a much bigger market. For us in North America, at least. And so we're rarely giving this anymore. It's not really that available. We had discussed over time a reduced intensity allotransplant with her del17P. She was really not interested in that. She cares for her husband who actually has MS quite significantly. So, didn't feel she'd be able to do that. So then we were also looking at clinical trials. So what clinical trial? Well, I think the exciting drug that's coming down the line are these non-covalent BTK inhibitors. So they are highly selective for BTK. This is pirtobrutinib. It was also called LOXO 305. These are reversible. So they bind, they don't stick and bind. They're reversible. And it's thought that this changes their ability to drive resistance mutations, although there are now some mutations that have been seen. they at least work in patients who've developed resistant mutations to the covalent BTK inhibitors. So the big study that's been done with pirtobrutinib is called the Bruin study, and they did a phase 1 dose escalation followed by phase 2. They have many different cohorts, but the biggest one is the CLL cohort, and they keep presenting this at different meetings with different cohorts. And here is the waterfall plot for the CLL cohort. And what's really amazing here is, so this is, the majority of patients respond, but all the patients in blue have had prior BTK inhibitors. The ones in dark blue had previously progressed on a covalent BTK inhibitor, so either ibrutinib or acalabrutinib. And the ones with stars here have known BTK inhibitor mutations. So these patients, this drug actually works in patients who've developed resistance mutations to ibrutinib. And then safety-wise, it looks really good. So this is all the different lymphomas that have been treated with pirtobrutinib, so 700 patients. The rates of AFib, only about 2.8%. So it's looking really, really good here. So I think pirtobrutinib, and there's another non-covalent BTK inhibitor that's undergoing clinical trials called nemtabrutinib. We were really trying to see if we could access this for her. I think this is kind of the next one that's going to be coming for this particular unmet need. What about other therapies or just other strategies? This wouldn't be useful for her, but as mentioned in the other talk too, there is a lot of people looking at MRD-driven approaches in CLL. In terms of clinical trials, there's many, many out there of novel drugs. I think actually some of the interesting ones are with this new type of drug called BTK degraders. We have a current clinical trial looking at a different target, something called ROR1, which is seen on embryonic cells, but also on certain hematologic malignancies. So it's an antibody drug conjugate to that. Bispecific antibodies, certainly not as far along as they are with follicular or DLBCL, but there are studies looking at those. And same with CAR T-cell therapy, not as far along as DLBCL, but definitely a number of studies looking at that. And then, as mentioned, reduced intensity allotransplant, which we still do for CLL patients who are high risk or have had relapsed with del(17p). So for her, she wasn't interested in pursuing an allo. I found out that there actually is a pirtobrutinib access program in Canada, but for CLL, patients need to be what they're now calling penta-refractory, which means they've progressed after chemotherapy, rituximab, BTK, BCL2 therapy, and a PI3 kinase inhibitor. So I would have had to give her that. She was really not interested in that. She has family in the US. She was looking at clinical trials. We talked about our ROR1 clinical trial in Vancouver. But actually, in the end, she also has family in another city in Canada, Calgary, and she opted to go for a trial with nemtabrutinib in Calgary. So she's currently on that clinical trial. So I'll just wanted to finish the last 2 minutes talking about the International Workshop on CLL's Global Partnership Subcommittee. So I am a member of this committee, and I think, with everything that I just talked about, I think it's very clear that these drugs are being rapidly developed, but cost is a major, major concern, and access is a major concern. Oh, apologies. I see there's a question. Should we take, I just have a couple more slides. Maybe I can, I'll come back to the question at the end, and we can certainly go back to previous slides. So the Global Partnership Subcommittee is chaired by Professor Anna Shu from Oxford. And there's a number of different CLL treaters from around the world on the committee. And the goal is to improve outcomes of patients with CLL globally through clinical training, research capacity building, training future academic leaders in CLL research, and raising awareness of CLL with patients, funders, and industry. One of the major goals is to facilitate access to targeted therapies that have shown significantly improved survival rates in patients with CLL. And they're really trying to model this after what happened with CML when imatinib came along. And there was really a push to have imatinib available in across countries by partnering with pharmaceutical companies, with other foundations. And so now the Global Partnership Committee from the IWCLL are really looking at this. And one of the combinations that's of interest is this oral combination of ibrutinib venetoclax, because it's all oral and it's time limited. So we'll see, stay tuned for that. There is a focus on patient advocacy, which I'm very interested in, trying education, and then grants and awards. So don't know if you're aware, but there was a call for an IWCLL capacity development project, and they were to award, they wanted to foster the development of CLL-related diagnostics, management, clinical and translational research or registry development or patient advocacy in low and middle income countries. And it was quite a significant grant for 1 to 3 years. It was put out and there was a very short timeline, and this was the first year we've put this forward, and there was a big recognition that we didn't advertise, I would say, or get it out there enough. And so, I'm very interested in ensuring that everyone hears about these kinds of things and has an opportunity to consider them for their communities. I'm also part of something called the CLL Advocates Network, which is a patient support, basically a global hub for different patient support networks and patient support groups globally. And one of the first things that they've done is to try to create this resource hub, which they have on their website, where people can search by region and see all the identified patient support groups in those regions. And the CLL Advocates Network wants to help regions that don't have a lot of patient support groups actually develop these patient support groups. So if you click on Asia Pacific, here's part of the list, it keeps going, but part of the list for Asia Pacific. And for India, there's only 2 associations that have been noted. And again, these actually don't have to be just CLL patient support groups. It could be general cancer, general blood cancers, or general leukemia groups. So I believe VCare is actually a pediatric group primarily. But I'm very interested if and would love to hear if there's other patient support groups that you're aware of, and try to increase the knowledge of the existing resources and potentially help develop new resources. So in conclusion, our novel targeted agents have dramatically changed the landscape of CLL treatment. Algorithms for CLL treatment should consider risk. We have to weigh the pros and cons of indefinite therapy versus time-limited therapy. We know that head-to-head trials show less toxicity with the 2nd and 3rd generation BTK inhibitors. We have novel targets in cellular therapy coming down the line, and a major unmet need is to facilitate access to these very costly therapies that are coming, and capacity building for increased clinical research and patient advocacy internationally. So with that, I'll end, and I'm happy to take discussions and very interested to have a further discussion with the group.
Thank you so much, Dr. Elena Gedi, for a wonderful lecture. Excellent and superb lecture, I may say. So we have got some Indian colleagues over here as our discussants who will discuss with you. I request all our discussants to please put the raising signs. And to start with, we have Dr. Pooja Prasad with us. Dr. Pooja Prasad, your question, please. Yeah, Dr. Pooja.
I made her wait too long.
Yeah. Okay, I'll come back to Dr. Pooja. Dr. Roshni Pandey, your question, please.
Good evening. Thank you for that lovely talk. I had a couple of basic questions. One is, how many months should we wait before we say that the lymphocytosis is not due to the BTK inhibitors, and before we say that that therapy has failed for the patient based on lymphocytosis?
Yeah, excellent question. So as you know, there is this redistribution lymphocytosis when we start a BTK inhibitor. I noticed it primarily in the first 1 to 2 months, although it can take longer. And then it can take a very long time to recover. And I've had patients who've actually never recovered. One of my patients, he started with a lymphocyte count of about 400. He went up to almost 600, over 600. I was very worried as this was happening. And then now he's slowly come down over years, and he's only at 100. And he just sits there at 100. And many times I've wondered, oh, he's not had a good response. I need to do something else. But he's actually clinically well. He has lymphadenopathy completely resolved. I've scanned him, no lymphadenopathy. And I feel if I change treatment, I'm just treating a number. I'm not treating his disease. So for him, I've just left it. Now, I realize your question is more, if it keeps going up, when do you start to become concerned that it's progression of CLL? I would think after, I would like to see it at least stabilizing or turning down within probably on average a few months. So I would say if it's still going up, you're into month 5, 6 or beyond, I would be worried that something else is going on. Has that been your experience, or what's your experience been?
Yeah, actually one gets a little impatient. One expects, the response to come a little faster. Even couple of months, more than 6 months is, the patient keeps on asking, why is it not coming to normal? But
yes, and actually with BTK inhibitors, I would not, so as that example that I just gave, we don't expect it to get to completely normal. If it just settles out around a lymphocyte count of 10, say, I know my numbers are slightly different than yours, but for my units, but if it gets to around 10, above 5 is abnormal for us, I'd be happy just letting it stay there. We know with BTK inhibitors, we're not going to get that deep MRD remission. We're not expecting that. It's kind of a lid that's on the CLL, but I feel the CLL is still lurking there. And that's why we aim to keep going on it as much as possible. Yeah.
Yeah, the second question is for patients planned for observation. Are frequent infections an indication to treat, or should we just do the IgG levels and put them on monthly IVIG?
Well, I would do that. Yeah, good question. I would do that first. But if they're persistently having infections despite IVIG replacement, that's very tricky because, of course, we worry that treatment's going to also increase the risk for infection. But I can think of off the top of my head 2 patients where I did treat just for persistent infections that were non-resolving. And it was a bit tricky at first to get past that. We used prophylactic antimicrobials and antifungals, and then they did get over that hump and did improve. Actually, one in particular I can think of had this chronic pseudomonas and kept having exacerbations, and it completely improved after she kept having the exacerbations, probably still about a year on BTK inhibitor, but then after that, none since. So yeah, I do think that's an indication.
The third question is for patients with hepatitis B activation, when we need to start BTK inhibitors, how long should we wait before starting once we start the antiviral therapy?
Who've had an actual reactivation?
Yeah, when the patient is to be started on treatment for CLL, the patient has had a reactivation. And so how long can we wait?
I think, and I take this also from my other lymphoma patients and with our hepatologists, as long as they're on treatment for the Hep B reactivation, and we only are allowed to check the Hep B viral load every 3 months from our government. So I had a recent case actually where they had a very high viral load, but there was a lymphoma patient, so it was urgent. I had to start treatment. They said, don't worry, just start the treatment. We've put them on the antiviral and we'll check. And as long as eventually, if it's coming down, they're not concerned about that. So I think if you can treat them with an antiviral, then I think it's fine. We also prophylax our patients who are Hep B core antibody positive, even if either surface antigen positive or negative, but even if surface antigen negative, we will give them prophylaxis. Currently now we're using entecavir. We were using lamivudine for the longest time throughout their BTK inhibitor therapy and for 12 months after. It used to be 6, we've just changed it to 12 months after. I don't know what your practice is.
Yeah, and in that GLOW study where you used a combination of ibrutinib and venetoclax, is that ibrutinib interchangeable with acalabrutinib?
Yeah, well, good question. So there's kind of a similar trial that we participated in Vancouver as well. I think it was, trying to remember its actual name, ACE 311 was the number of the trial. And it had acalabrutinib. It was comparing chemoimmunotherapy. It was FCR or BR, depending on age, versus acalabrutinib venetoclax versus acalabrutinib venetoclax obinutuzumab. So basically, it's not interchangeable based on the GLOW data, but there are clinical trials coming with acala and even zanubrutinib. So I think that we we won't know really until those trials report. They haven't reported yet. But I suspect it'll be less toxicity, at least. Whether the efficacy will show the same thing, I don't know, but I think there'll be less toxicity.
And any role of chlorambucil today? I mean, in India, we still need to use it as a backup therapy.
Fair enough. And we still have it as an option here. And currently for us, though, where we have other options, I mean, in general, if you want to give time-limited therapy to an older patient with comorbidities, I mean, I still give BR quite a bit to older patients. So I'm quite comfortable with that. But there are many patients who I'd like to give Ven-O, but if they're older with many comorbidities or cognitive, they wouldn't be able to do that. So I only use chlorambucil for a very select kind of group of very older, really have contraindications to everything else. But as you know, if you're using it, it works. And if the goal is just to improve symptoms, if you're not necessarily aiming for that prolonged remission, we do know it works, and we do know it can even induce MRD negative remissions based on prior data. So, yeah.
Thank you so much.
Yeah, you're welcome.
Thank you, Dr. Roshni. Dr. Pooja, are you there?
Yes.
Yeah.
Hello. Good evening, Dr. Elena. Thank you for the wonderful presentation, and my apologies for my previous technical error.
No problem.
So I just wanted to share my experience of this patient of relapsed refractory CLL in whom I used this combination of venetoclax and obinutuzumab. So this patient did not have any 17p deletion. He had previously received multiple lines with rituximab, chlorambucil, as well as bendamustine rituximab. Then he responded to ibrutinib, and he was in remission for 2 years, after which he progressed. So for this patient, I started with venetoclax obinutuzumab. And as you had said, there were similar problems of lots of neutropenia as well as thrombocytopenia. Until now, I haven't been able to ramp up the venetoclax dose to the maximum of 400. He's still being continued on 50 and sometimes on 100, but he continuously develops this thrombocytopenia. Even though other parameters are very much in normal, he has completed 6 cycles of obinutuzumab. So my question is, since he has already progressed on ibrutinib, we can't use other BTK inhibitors in the next setting when he'll subsequently relapse. Is that right?
Absolutely. Yeah. So good question. And yeah, that sounds like a really challenging case. It's concerning he progressed after only 2 years of BTK inhibitor. We've actually with Ven-O, I'm noticing more and more these cytopenias, and I wonder, I don't know how long it's been since he finished the obinutuzumab, but it could be the obin. I actually had a recent patient who I think developed almost like a ITP. Every time they got the obin, the next day their platelet count was pumping. But maybe now that the obin's done, maybe you'll have a better chance to be able to ramp up the venetoclax. Sometimes you might just end up staying at a lower dose. Usually I'd at least try to get up to 200 and then just stay at that dose. I've had patients there. But then your question about what to do next, I mean, that is exactly the case. At the end, I was discussing just this idea of, I think this is the unmet need currently.
Yes.
And, I think the easiest thing is going to be the non-covalent BTK inhibitors once they're available. They're oral, they're easy, there's not a lot of side effects, but there's really no role in going to another covalent BTK inhibitor. I mean, the data that zanubrutinib is more efficacious than ibrutinib is intriguing, but I don't think, to me yet, that means that we could switch to it. The one time I've considered switching, even in the setting of progression, has been in patients who weren't on full dose ibrutinib. So I have a lot of patients who, eventually had to be dose reduced or never made it up to full dose ibrutinib, and now they're starting to progress. And just to try to buy more time out of the BTK inhibitor, I've suggested switching to, say, full dose acala, which maybe they'd be able to tolerate, even though they couldn't tolerate low dose ibrutinib, or couldn't tolerate full dose ibrutinib. But otherwise, there's really no role. I mean, if it's all you have, you could try it, but I don't think it is possible. So actually, I have discussed with some other CLL physicians, from Jennifer Brown from the Dana-Farber in particular, about this. And they've kind of anecdotally noted that after someone's been on venetoclax for a while, if you add back in a BTK inhibitor, you might, even if they've progressed on it before, you might be able to regain some control.
Yeah,
And
so we can
way to buy some
re-challenge
time.
with another BTK inhibitor and see, because can we re-challenge with ecal now that ibrutinib was given around a year back? So maybe we can try with that. Do you think that might work?
Yeah, I would try adding it in. I mean, you're going to be limited though with the thrombocytopenia is going to be a problem in that case. Yeah, I think this is really the hard place to be. I mean, I think if he was truly progressing, you might need to think about chemotherapy again if that's all you had. Yeah, I think this is exactly the challenge that we're in now, where the big unmet need is.
Okay. Also, another question: what is your schedule of any vaccination that you give to these patients on BTK inhibitors as well as venetoclax?
Yeah. So we try to get them all in before they start, especially for the BTK inhibitors, because as you know, just like monoclonal CD20 monoclonal antibodies, once they start, I mean, they're not going to respond. If they need vaccines and they're on a BTK inhibitor, I would still say to go ahead and get them, particularly COVID. We also still give annual flu vaccines, but I always tell them that we don't know how you're going to respond. You might not have any, you'll probably have some response, but not a great response. So yeah, don't have a good answer there. Certainly once they stop, if they're ever on a treatment break, I try to get them quickly to get any vaccines that they haven't had. But yeah.
Okay, and unrelated to this case, I wanted to know whether if a newly diagnosed CLL patient who's asymptomatic as such, but has a 17p deletion on FISH, does that become like a clear-cut indication to treat, even though the CLL IPI score is coming out only around 5 or 6? With the addition of 4 points for 17p?
Yeah, so yeah, good question. I mean, that based on what I was presenting at the beginning, I think a lot of people are wondering that, and especially with the new drugs, there's this temptation to want to jump in, especially for high-risk patients. But so far, the data does not support that. There was that one trial looking at ibrutinib versus observation for high-risk asymptomatic patients. There was an improvement in event-free survival, but no difference in overall survival. And I think the feeling is, you know, you want to wait it out until you really need the treatment, because we know, especially with deletion 17p, we're going to have short windows. Once you do start the treatment, it's going to be short.
Okay.
But that question is being relooked at now with Veno, but for del 17p, probably not the best thing anyway. So although it's nerve-wracking to know that they have del 17p, I would still just sit on it and only treat once they develop symptoms.
Okay, thank you so much.
Thank you, Dr. Pooja. Dr. Agrawal, sir, you had a question?
Yeah, I had a question, but Pooja's questions cover that.
Okay. Right. Dr. Miyatsue, your question, please.
Hello.
Hello.
Hello. Thank you so much for your excellent presentation. Today, I would like to know one question. This is about the histologically aggressive CLL. It means the pro-lymphocytic CLL. How to monitor those cases, and how often need to do the bone marrow examination for histologically aggressive CLL?
Yeah, good question. Yeah, I didn't really talk about other kind of forms of CLL, even Richter's transformation. But so pro-lymphocytic leukemia has actually recently been recategorized in the WHO. It's now kind of put back into just general CLL. And that is how we're meant to treat it, I think, just similarly to CLL. So we can use all of the same agents that we use. I don't think I monitor them. To be honest, I mean, it's such a rare phenomenon. I only have a few patients in my practice, and I think I would monitor them similarly. I don't think you need to keep repeating marrows, you know, to see if it's progressing, unless there's clinical indications, you know, cytopenias. But really, you're going to treat them like you treat CLL. So I don't know that it would make that much of a difference. You might want to follow their blood counts more frequently. That's easier to do. But yeah, I don't think I would apart from if you're doing a marrow diagnosis because you're looking for PLL, then yeah, I wouldn't necessarily do them more frequently.
Thank you.
You're welcome.
Thank you, Dr. Sway. We have got couple of questions now from the audience.
Sure.
One question directed to Dr. Priyanka Samal. You said about management of if patient develops hypertension and atrial fibrillation well on ibrutinib or acalabrutinib. How do you manage those patients who are developing very severe hypertension? Any
Great question. So when all we had was ibrutinib, we would just push through and we definitely just treat them, treat their hypertension. Well, I don't treat it, but I send it to somebody else or ask their general practitioner to treat it and advise them. And I think actually what's important is to let general practitioners know that, people don't know that ibrutinib is associated with this increased risk. And what I've actually found recently is patients aren't getting blood pressures checked potentially. And so it kind of goes undiagnosed for a while. So that's another key thing, is to ensure that your patients on BTK inhibitors are getting regular checks of their blood pressure. And then treating as you would treat normal hypertension. For AFib, again, same thing. When ibrutinib was all we had, we would I'd pause it, hold it when they are having an episode. They usually ended up in ER or somewhere where it got kind of treated. They get treated as normal and started on anticoagulation if required. And then I would restart the ibrutinib. So I have many patients who are on anticoagulation, not warfarin. That's contraindicated, but other DOACs and other aspirin, et cetera, is fine. There is an increased risk of bleeding, and we would just kind of explain that and make sure they're aware. Now, I have many patients who are still on ibrutinib because that was the first one I started in them. And if they're tolerating it well, I haven't switched them to a second generation BTK inhibitor, but I have a low threshold now. So if they are developing hypertension that I think is related to the ibrutinib, if they develop AFib, I would switch them to acalabrutinib or zanubrutinib, which we have. So I don't switch. I am not switching all my patients, but if they are developing these cardiac toxicities, I have a low threshold to switch. And then very rarely have I had to stop BTK inhibitor completely because of cardiac events, not because of hypertension. I have for AFib, recurrent AFib, or someone who has a very severe episode. And the other point about indefinite BTK inhibitor therapy is now I've got many patients in my practice who have been on for 5 years or more. Many of them are in a good remission, and something might happen that makes you start to think, should we stop? So actually I have a recent patient, she's a physician. She's been on ibrutinib at 280 milligrams, a lower dose, for almost 6 years now, I think. And she's just developed hypertension. So we were just having this conversation and we've decided to just fully reevaluate her CLL. So I'm going to do scans and flow cytometry. Her lymphocyte count's normal. I'll just repeat the flow to see if there's there. We don't have MRD testing because it's not really used to guide management. So we don't have it publicly funded. But my plan is to kind of reevaluate her CLL. And if she seems in basically a remission, I think we're going to just stop the ibrutinib entirely. And, this comes up for patients, not just for hypertension, but for various things, maybe just other side effects that they have, or they're just tired of taking it. As long as it's been 2 years, I would say, and they're in a decent remission, it's reasonable to stop the BTK inhibitor. We don't know that there's anything wrong with stopping and then waiting till they progress again. You could always restart it. They haven't progressed on it, so you can always restart the BTK inhibitor. And I think what'll be really interesting, I didn't touch on sequencing of these drugs, but over time, I think we're going to get more and more real world data looking at how patients do when we take a treatment break in the middle. And, this isn't CML. We're not trying to target this low, PCR levels. We can accept that they have some disease, even if their lymphocyte count's kind of 10, but they're tired of taking their ibrutinib, it's been forever, or they develop some toxicity, you can stop. And I would only switch treatment if they actually have a current indication for treatment. Or to me, if it's been in the first 1 to 2 years, I worry that if you stop it, then you might get that flare. But if it's been a long time and they're doing really well, I'm very comfortable stopping it.
Thank you, Dr. Giri. Dr. Priyanka Samal, you have a question?
Yeah. Thank you, Dr. Alina, for that wonderful talk. So I have a query. Suppose if a patient, most of the time FCR regimen works very good, but in India, because the incidence of infections is very high, the neutral is so prolonged in FCR. So it's difficult for us, and we have used bendamustine rituximab for patients who are 60 to 65 years or 70 years.
Yeah.
So in that case, if a patient after 6 years of 6 cycles of bendamustine and rituximab, if he enters into a PR, would you continue to observe the patient and wait for further symptoms to reappear and then treat the patient, or would you like to put the patient on a BTK inhibitor?
Yeah, I that you had a case like that, but it was mantle cell lymphoma, right? So a little bit different for mantle cell. I think for CLL, no, I would just stop after the 6 cycles of BR. I would just accept they're in a PR. I feel like our view of CLL has shifted in the last 10 years. Now we're aiming for, CRs and MRD negativity and all this stuff. But actually, no one worried about that before. Before, it was all about just controlling the disease and getting their symptoms under control and then monitoring over time. I think they would still have an excellent PFS, even if in a PR. It could still be years before they need treatment again. So I would just stop after the BR. Yeah, in that kind of a scenario.
Yeah, and the second question is, in a case of TPLL, right?
Yeah.
What options available there? We do not have much of options. Alemtuzumab is not available. On compassionate ground, we have it. And by the time it comes, it is such an aggressive disease, we lose the patient.
Yeah. We have IV alemtuzumab, and that happens too. It's even having it, it's such an aggressive disease. So we do use IV alemtuzumab for TPLL, and essentially try to get patients to allotransplant if they're young and fit. But otherwise, so if you didn't have alemtuzumab, I've also accessed pentostatin. I don't know if you have that. I've been able to access that. Again, it was a very convoluted, compassionate program from the US, but that patient progressed quite quickly eventually. I think I would use probably just standard chemotherapy, cyclophosphamide. I haven't had a case in a very long time where we haven't been able to use alemtuzumab. What have you used?
Bendamustine. We used bendamustine.
Yeah.
It didn't really work out very well.
Yeah.
1 or 2 cycles, there was symptomatically a relief, a little bit of relief, but then after that, he again progressed post two cycles.
Yeah, I think it can be such a terrible disease. I think your only chance would be if you could give some chemo to just cool it down, and then I don't know if you're in an allotransplant is an option, but that's what you would try to get them to. But again, my last 2 patients have not been able to get to allotransplant, even with alemtuzumab.
Thank you.
Thank you, Dr. Priyanka. One question from Dr. Nishan Jindal. What are your responses to second generation BTK inhibitors? The patient progresses on ibrutinib, and is there any cross resistance based on mutation profile?
Yeah, so that kind of is similar to a question we discussed earlier. So I don't switch to another second generation inhibitor if they've progressed on ibrutinib. I think the whole class is kind of out if they've progressed on a covalent BTK inhibitor. We'll see with zanubrutinib if anything comes of that, if it is more efficacious. But the thing is, the mutations are the same. So to your question about mutation profile, they still get the same BTK mutations, the C281S and the PLC gamma 2 mutations. So the difference is, though, the non-covalent BTK inhibitors like pirtobrutinib, they don't get those mutations. We now know they can get other mutations, but less frequently and not cross-resistant. So hopefully those come along eventually, and we can access those, because those will be the drugs, I think, of choice after progression on ibrutinib.
Thank you. Another question from Dr. Saswata Saha. Is it easy to start venetoclax-based therapy in a patient who has got CLL, rise stage 4, with anemia and thrombocytopenia upfront? And should we consider the slow ramp up of venetoclax or same dose of venetoclax with transfusion support?
Yeah, good question. It's very interesting. I've now used quite a bit of Ven-O. So you guys have access to Ven-O?
Yeah.
I mean, okay, it's there. It's just if patients can. Yeah. Okay. So I don't know if you've used it much. It's some patients sail through it, no problems. It's great. They do great. Other patients, though, I'd run into significant problems with cytopenias, and so. As you know, kind of the mantra with leukemia in general, if someone has pancytopenias or any cytopenias due to their disease, we just press on with treatment with transfusion support. But in CLL, it can get quite tricky. I think I still would, you know, with the Ven-O regimen, at least your first 4 doses are just of the obinutuzumab, and you might start to see some clearance of the marrow with that obinutuzumab, which might help your cytopenias before you start the venetoclax. You can always slow the ramp up down even further. You know, you can go to, I actually have a patient I'm about to start on 10 milligrams for her ramp up. She had 1 dose of venetoclax and her LDH skyrocketed. Fortunately, she hasn't had bad TLS, but I think it's because of her disease just breaking down. And so I want to go even slower. So I've heard, you know, you can start at 10 milligrams, you can do 2 weeks or even 3, you know, there's no, depending on your urgency to get the disease under control, you can spread out that ramp up. I haven't actually done that yet, but I know of colleagues who've done that. That's a very tricky scenario if they've already got cytopenias. I think I would still go for it with transfusion support. I might admit that kind of a patient if I could. Yeah. But tricky.
Thank you so much. Another question he has, for a patient who is FISH negative, IgHV unmutated CLL, cross-trial comparison shows better PFS with ibrutinib compared to Ven-O. So which one would be your first choice now?
Yeah, and that's what I was sort of getting at with that first case I showed with a gentleman exactly like that. Normal FISH, no del-17p, but unmutated IgHV. And that 5-year data that I showed, there is worse PFS with unmutated. It's about 53% at 5 years, compared to about 75% for mutated at 5 years. So to me, as long as they don't have del-17p, I still feel like we have other treatments for these patients. So I'm not, you know, that extra. It's about a 13-15% PFS. It's not make or break for me. I think it really comes down to, if you have both options, is a discussion with the patient, what their preferences are. You know, you're talking about indefinite therapy. So for younger patients, you know, that maybe is not ideal compared to time limited, where it's only for 1 year. And it's funny, I also have to check my own biases. I had a patient recently who's 86. And he was otherwise well and healthy. And he had, I can't remember if he's mutated or unmutated, but I was presenting him with both options with, I think he's mutated. So I was presenting him with BTK inhibitor versus Ven-O. And I thought, of course, he'll just choose BTK inhibitor. It's just a pill he'll take for the rest of his life, not a problem. And right away he said, well, you know, I want the one that finishes after 1 year. I don't want to be on treatment for more, like for forever. And so it just made me realize it really is important to have that discussion with the patient. And he started Ven-O and he's doing well. But he's a fit, well 86-year-old. So then, you know, it comes down to also your comorbidity profile, their age, and then their preference. Personally, as someone, so in British Columbia, I'm quite involved with getting our drug protocols up and going and thinking about our drug budget and what drugs we should fund and what not. So I think that if we give everybody indefinite BTK inhibitor therapy, we're completely going to break our bank and we're not going to be able to give other treatments that we want. So I really do want to give people Ven-O if it's appropriate for that patient. And I think it is for unmutated IgHV. And in speaking with other CLL physicians internationally, I think many people feel that way. There are some, though, who say, no, for unmutated, you should only give BTK monotherapy. But I think a good portion of them also agree that Ven-O is very reasonable. Time-limited therapy is reasonable for that kind of a patient.
Thank you. Another question she has is, with this current availability of BTK inhibitors, BCL2 inhibitors, and combinations and so on, where will you place PI3 kinase inhibitors in your CLL treatment?
Yeah. So the only time now, I think they're actually going to make a brief comeback before they go away again, because we're in this period when patients progress after a BTK and BCL inhibitor therapy. At least for me, that last case I showed, I'm kind of scrambling to figure out what to do. And if I needed something to really bridge somebody or hold them while waiting for something else, so that could be, for us, often it's allotransplant. We're waiting for workup, we're waiting for all of that. Waiting for a clinical trial. Sometimes we know we have trials coming, but they're not open yet. And, we're waiting for that, or trying to send them somewhere else. Or even waiting to get pirtobrutinib. I've actually gotten it for a few mantle cell patients. It takes almost 3 months just to get the paperwork going, and because it's a compassionate access program. And so if you really needed something to bridge somebody, I think that's where I would use the PI3 kinase inhibitors. If patients have progressed after BTK inhibitor or BCL2, their median PFS with IDELA-R is about 4 months. So it's a potential bridge, 4 months maybe on average. But you got to have a plan for after that. And as I mentioned, to get Pirto in Canada for CLL, they've coined this term, which we usually use for myeloma, but penta-refractory, where they had to have had prior exposure to a PI3 kinase inhibitor, and that's because that's what their original clinical trial, their phase 2 trial. All patients with CLL had to have had prior. Actually, I think it was their phase 1 trial. Had to have had prior PI3 kinase therapy. So it is still out there. It is still an option as a bridge. And we almost did it for my patient. And then because she was such a slow progression, we just held off and waited. And then we got her onto a clinical trial.
Thank you. Another question from Dr. Nishan Jindal. He said, will atrial fibrillation revert in some patients who has been switched to second generation BTK inhibitor from ibrutinib?
Sorry, what was the first part of the question?
If the patient develops atrial fibrillation on ibrutinib, and then you switch over to second generation ibrutinib BTK inhibitor like acalabrutinib, will atrial fibrillation again take place in that patient?
Yeah, good question. There's probably some people have looked at that. I don't have data off the top of my head. Anecdotally, I've seen it improve, but absolutely there's still a risk. And actually, in the Elevate-RR trial, I remember we were waiting for a long time for that to be presented. And I think they waited until 5-year follow-up before doing any presentation. And so I was really hopeful there was going to be like a stark difference in cardiac events and AFib rates. And there was a difference, but it was not as much as I had thought. It was 16% with ibrutinib and still 9% with acala. It still happens with acala. And I think actually the first speaker presented a case with acala where the patient had quite bad AFib and cardiac issues. So yeah, it does still happen. So I think there is still a risk. The thing is, once someone has AFib, then they're usually put on treatment for AFib. So then they're kind of less, in some ways, they're protected as long as they don't have like quite bad AFib where it's really recurrent. But usually they're already on a beta blocker, and they might have been cardioverted. I don't know. They've already had the treatment for it. So in some ways, you're not as concerned because they're already on the beta blocker.
Thank you. Another question is from Dr. Sindhu. He wants to know that if the patient progresses on ibrutinib, can we directly switch on to acal or zanubrutinib?
Yeah, so I think we've touched on that a couple of times. So no, I would not. I don't think you're going to get any more mileage unless, as I said, if you had someone who maybe was on a low dose of ibrutinib because of toxicity and you want to try switching to a full dose of a different BTK inhibitor. But even that, I think, might buy a bit of time, but I think eventually they'll progress because the mutation profiles will be the same between those.
And the last very simple question from Dr. Vinayak Chikodi. He wants to know, do you do bone marrow in every case of CLL?
Do I what, sorry?
Bone marrow biopsy for every case of CLL upfront?
No, definitely not. I almost never do a bone marrow. The only time I do are for clinical trials because they need them. Or if there's something else you're worried about, cytopenias, you can't figure out why. If they transform to Richter's, then I might do it as part of the staging. But, and in SLL, we didn't talk, everything I've said here, the same treatment we do for SLL. So in SLL, I often do the marrow as part of my staging, just like other lymphoma.
Thank you. Last two questions have come up. Yeah, sir has a question.
Dr. Arina, first of all, thank you very much for being with us. If there is a patient who has no atrial fibrillation, no hypertension, but ischemic heart disease, multiple stents, undergone CABG, is that person okay for a BTK inhibitor, or you will go straight for the BCL2?
Yeah, I mean, I think I would, good question. I think I would put that as part of the decision making that I'd be using, right? So that goes into their comorbidities. I think they're still appropriate for a BTK inhibitor, but I would definitely prefer a second generation BTK inhibitor. And again, when that was all we had, we wouldn't think twice. That's what we would give them. Now that we have Ven-O, and I like to try to give Ven-O for many patients if I think, as long as they don't have deletion 17p, I would try to give Ven-O if it was appropriate. But I don't think it's wrong to give a BTK inhibitor at all. And definitely if they have deletion 17p, I would give that.
One more question.
I do worry about those patients still. We know that even without hypertension, we know that it's not just hypertension and AFib. There's this signal of sudden cardiac death. That's with ibrutinib that we don't understand why. And so these patients with more cardiac disease, I do worry about them.
Thank you. One more question. A patient deletion 17, unfit for BTK. See, you have started BCL2 plus Obino. It's done very well. 1 year is over. But because it is deletion 17, can I just continue venetoclax? Is there any duration-related toxicity of venetoclax?
Yeah, good question. So when venetoclax first came out, it was as monotherapy, indefinite. I haven't seen a lot of long-term follow-up from those original studies. That's actually something maybe I should look for, because I have not heard of long-term toxicities with venetoclax like that. Like we know with the BTK inhibitors, there's just ongoing risk of infections and all the same stuff keep happening. When the Murano trial, which was in the relapse setting, where they got venetoclax rituximab, I know then it became a big question of if you would give that to patients with deletion 17p. And I think a lot of places where they were able to access ongoing venetoclax, they would. After the end, that was 2 years. And after the end, people would still continue on the venetoclax. But in that trial, they did look at the data, and it looked like patients they looked at MRD levels approaching that 2-year mark. And patients who were going to progress already were starting to have MRD positivity prior to that 2-year mark. And so the feeling is, I don't know if you're making any difference by ongoing venetoclax. They were already starting to progress before. That being said, in the case I showed you as an example, I did continue the venetoclax. I don't know if that made a difference or not. So I really don't think we know. And there's some people who think, no, there's no point, because if they are going to progress, they've probably already started. But if you could continue it and access it, I think we know that when people stop it, that's when the curve starts to go down. So if I could, I definitely cannot get it anymore. And definitely not after Ven-OB. I would not be able to continue it. So I think I would just, I'd have to stop, but if I could, I think I would. Yeah.
Thank you.
Thank you, sir. Another question from Dr. Thant. He wants to know, do you have any experience of developing SLL, small lymphocytic lymphoma, from a patient who has developed Hodgkin's lymphoma or a high-grade lymphoma post chemotherapy for that, or immunosuppression for that?
Sorry, what was the first part of the question?
The patient develops Hodgkin's lymphoma, or a patient has got a high-grade lymphoma, and patient is given chemotherapy or some immunosuppression for the same. Whether you have got any experience that patient developed small lymphocytic lymphoma post chemotherapy for Hodgkin's lymphoma or any other high-grade lymphoma?
Oh, so Do you mean someone who'd had a pre-existing diagnosis of CLL, SLL?
The existing diagnosis of Hodgkin's lymphoma or say
Okay.
BCL, now given
I
chemotherapy.
mean, if
After-
they developed CLL after DLBCL or Hodgkin's, I would wonder if they had it all along and it was just missed at you know, that their original DLBCL or Hodgkin's was actually a transformed lymphoma, and that we just kind of missed the original CLL, SLL, because I mean, it'd be high. Well, we know patients can have more than one lymphoproliferative disorder. You always have to wonder that they're related in some way. And I think often if I saw it in that order, I would wonder if I just missed it at the beginning.
So it cannot be therapy related CLL?
It cannot be.
Therapy related CLL or SLL?
Oh, no. I mean, no, I don't think that's really reported. I mean, certainly therapy related myeloid disorders, but not lymphoid. Yeah. Yeah.
And the last question from Dr. Humaira, how long time it takes for normalization of lymphocyte count with ibrutinib therapy?
Yeah, so it can take months. I mean, generally, I think the average is within the first kind of 3 months, it starts to normalize. But as I mentioned, I've had patients that have never normalized. So they've carried on with high lymphocyte count. And one of mine, the lymphocyte count's in the hundreds. He started at 400, went to 600. Now it's come down to 100. He's been on it for years. And every time it goes down a tiny bit, and he's completely well. So I've just carried on. I feel like if I do anything else, if I switch treatment, it's just to satisfy my own anxiety about his lymphocyte count, but he's otherwise completely well. So yeah, it can last a long time. And with ibrutinib, or BTK inhibitors, I don't always expect it to completely normalize even. And that's fine. They can just sit at a low level and you just watch them.
Thank you.
So I have questions for you guys as well. Can I ask a question? I know we probably have to go soon, but you have such great questions. How much CLL do people see in their practices, given the incidence seems so low based on the data, epidemiologic data?
I think I would say we have 4%, 3 to 4% incidence of CLL.
Yeah. Okay. So you are still seeing it, just not a lot. And then, so you mentioned you do have access to Ven-O.
Yes, we have access to Ven. We have access to obinutuzumab. Ibrutinib is available. Acalabrutinib is also available now.
Okay.
Yeah.
And not zanubrutinib yet.
No zanubrutinib.
Okay.
The question which I have is, do you face any experience of getting vasculitis related skin rash when the patient is on acalabrutinib?
Vasculitis? Skin rash?
Like skin rash. Patient has been started on acalabrutinib and patient has got vasculitis like skin rash. Have you any experience with
biopsy?
On biopsies like vasculitis.
Yeah.
Patient has well responded to steroids. So
I have not. I've definitely seen rashes and weird skin things. And we've also seen many autoimmune things, both on BTK inhibitors and BCL2 inhibitors. And you never know, is that the underlying CLL that's caused this vasculitis or any autoimmune problem, or is it the drug? That's really interesting. Yeah, personally, I haven't seen it. I wonder if have you searched for it? Is that like done a lit search? I don't know if that's been reported. I would presume it has been, but I think how do you tease out if it's a CLL related autoimmune complication versus a drug complication? So what's happened with your patient?
Patient with corticosteroids, the patient becomes absolutely normal within 2 weeks.
Okay.
Yeah.
And you've continued the acalabrutinib?
Continue. We did not stop.
Yeah.
Right.
Yeah, it's good. It's good.
Thank you. So I've finished all the questions from the audience. If anybody has any question for Professor Gary or Dr. Priyanka Samal, please go ahead. Well, so there are no other questions from the discussants, and I've finished all the questions from the audience. Well, thank you so much, ma'am, for a wonderful answer sessions, as well as for your lecture. Thank you, Dr. Priyanka Samal, for a wonderful lecture. And thank you for hanging with us to the last moment.
Thank you, Amit.
Thank you so
Yeah,
much.
thank you. It's really, I've been thrilled. It's been really great to chat with you all. And I put my email address out there. I'm happy to answer questions or communicate again. And especially if you have comments on my last few slides about some of the initiatives that are ongoing, please feel free to contact me.
Sure. Thank you so much.
I can put it here again.
On behalf of MSG, thank everybody, Dr. Alina, Dr. Priyanka, Dr. Amit for anchoring the whole program, and Estra for sponsoring. And Dr. Alina, especially thank you to you.
Yeah, thank you very much.
Thank you, sir. Good night.
Thank you, Dr. Alina. Thank you, Dr. Priyanka. Thank you all of you for joining us. And thank you all the audiences for joining us this Saturday evening. Thank
Yeah,
you so
bye.
much.
Good night.
Bye-bye.